Everybody, and welcome to the first formal Health and Adult Social Care Overview and Scrutiny Committee of the municipal year. Before we start these proceedings, may I bring to your attention some of the housekeeping issues. There is no expected fire alarm today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. Please leave the council house by the front door and muster on the other side of the car park. This meeting will be broadcast live to the internet and will be capable of subsequent repeating viewings. By entering the Warspite room this afternoon, you're consenting to being filmed and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you are not using it. And also your mobile devices, can you turn them to silent, please? The focus of today's committee meeting is centred around urgent and emergency care. It is clearly evident that Plymouth health and care system is undergoing significant challenges at the moment, with the impact of COVID-19 further accentuating pressures across all partners. We recognise and appreciate the effort of all staff who have and continue to work in this challenging environment. However, it cannot be ignored that there are deep issues with urgent and emergency care provision. While many people at home and in this room are passionate and have emotional experiences of this issue, the committee must endeavour to constructively engage with these issues and what is being done to overcome them, producing recommendations and a drive for improvement on behalf of both the health workers and the residents we represent. So I'm expecting good, polite, but forensic conversations today, please, folks. So I need to ask you to note the appointment of Councillor Mary Aspinall as Chair and Councillor Mark Deacon as Vice Chair of this committee. Apologies. Do we have any apologies?
Yes, Chair.
Thank you, Chair. Apologies from Councillor Mrs Pengelly. Councillor Sue MacDonald has provided apologies. Councillor Lang is substituting. Justin Geddes from Devon Doctors is unable to join us. Councillor, thank you, Chair.
And I've had a note that Councillor Nicholson will join us about 3 o'clock because he has a work engagement this afternoon. So, folks, any members got any declarations of interest? No? Right, excellent. Moves us on to the minutes, which are on page 1 to 4 of the pack. Those of you that were with us back in March can probably make comment, but the only thing I picked up was item 38, which down the bottom it says daily numbers showed the number of people in receipt of domiciliary care since the start of the year have been increasing, which has a positive effect on the number of people waiting for care. Was that a positive or was that a negative, because it was causing a hiccup with getting the new ones onto the list? So can somebody check that, and then we can do that. Other than that, that was all I picked up. No, right, excellent, folks. Let's move on to Chair's urgent business. I haven't got any. Right, so that's good. That's good. Terms of reference. You've all got a copy of the terms of reference of this committee. It's what's basically written in the Constitution. And anybody want to argue the toss about anything? No? Right, okay. Item 7, policy briefing. Sarah, that's you? And anybody got any questions about the paper that's been put together about policy briefing? Because I'm sure you've all read it and all understand it. Sarah, I think from my perspective, I'm really intrigued about the last point that you've got there about grant funding launched to support women's reproductive well-being in the workplace, and that there will be grants. So I don't know whether that, I mean, obviously I'm not expecting you to make comment about that, but maybe that I now dump this on Craig and say, is there any thoughts that PCC will be putting in any bids to support our workforce? Or John, maybe John Mahoney has a thought on that.
I read it like you did a day or two ago, and I think it's quite interesting, but I don't know whether we're going to put a bid in.
Fine, so in that case then, if we can refer this to our HR colleagues, unless Sarah, you can add anything that to the conversation?
Not at the moment, but I can certainly see if there's any more information available that I can share.
Thank you for that. Anybody else got any questions they want to ask? Ian?
Thank you, Chair. I suppose to Craig, really. I noticed the item on increased funding for nursing in care homes. You're saying there's an increase of 11.5%, taking it to 209.19 pence. It seems not very much money, if I'm honest, looking at that and knowing the problems that care homes and nursing homes have. Now, I was just wondering whether Craig was able to comment on whether that's anywhere near enough or whether we're still miles adrift and to give people the full care they need. Thank you, Chair.
Thank you, Councillor Tuffy, for that question. That actually only applies to a very small component called something called funded nursing care. And that is quite a big rise within that area, more so than we were expecting. So that is good news in terms of that. In terms of the more general point, where as during I think we've highlighted to the committee before, we're doing something at the moment called a fair cost for care exercise, which is engaging with the marketplace to determine what levels of fees we should be paying going forwards. That review, Councillor Tuffin, is due to conclude during the summer months with findings going back to central government during the course of the year, and we think the target date for that is October. So we will be clearly bringing that back to this committee as well, Chair, but that will give us a fair cost for care exercise across the marketplace in its entirety.
Thank you. And Sarah, the better mental health support for people in crisis, it's talking there about there's a draft mental health bill and then there needs to be some work done within Parliament. Have you got any idea yet when the final version might be ready to come out to the wider world?
No, at the moment, all I can see is that pre-legislative scrutiny will start as soon as possible, but there's no dates allocated to that yet. So at the moment, no.
Can I suggest we keep an eye on that, folks, because that's obviously quite an important issue for us, particularly here in Plymouth. Right, thank you very much, Sarah, for your time, and thank you for diligently going through all the government policy and legislative announcements. It can't be the easiest thing to do, so thank you very much indeed.
Thank you, Chair.
Okay, Tony. There you are. Tony, welcome to the committee. It's always very good to have Health Watch come and see us, and we've all received a copy of the Health Watch annual report, and as usual it's amazing what you've got up to in the year when things have been fairly restrictive in many respects. So I'd like to ask you to outline what concerns you're finding over this last 12 months.
Thank you, Chair. I think the biggest thing that we're seeing is access to services and not any particular service. So it involves NHS dentistry, it involves GPs, it involves mental health, it involves children's services. It involves, in a way, access to urgent and emergency care because of the system pressures that are going on. And a lot of the work that we did in the last 12 months was either in support of the clinical commissioning group to find out some of that patient experience or individual engagement work that we undertook based on patient experience that was coming in direct to us. So just give a quick précis on the work we've done in support of the system. We, last summer, we undertook face-to-face visits to the 4 emergency departments in Devon, so that included Plymouth, Torbay, North Devon and Exeter. And that was to find out why patients had turned up at ED, and it was a bit of a mixed bag, if I'm honest about that. And it wasn't one particular issue that people were turning up there. So they were being directed there from either GP or NHS 111, or we even had one case, I think, where somebody was directed from community pharmacy. They've tried to access services, haven't got the answers they've want, or haven't been able to access, so they're turning up. I think the problems with NHS dentistry speak for themselves. You know, you just can't get hold of a place on a dentist's roster that's undertaking NHS package to work for love nor money. You know, and that's leading to people trying to urgently access the urgent care that's been put in place, but even that is having to be triaged to get the most urgent people in because of a capacity thing. So I think, for me, one of the biggest problems we're seeing at the moment is probably patient confidence in accessing services. And that can range from using the 999 system and being told that there's going to be a long wait for an ambulance, and then not knowing where they can go for additional information and support. We've had commentary from some people that when that happens, they're putting their relative or child into a car and driving directly to ED rather than waiting for the ambulance, which then doesn't help the pressure at the ED door either. So the triage process of sort of heart attack and stroke being the major priorities that the ambulance service has in place is kind of bypassed a little bit by people quite rightly concerned about their relative and needing that support and urgent care. Other work we've done in support of that, we did some work, in fact 2 lots of work around NHS 111. One was to test the campaign that happened in December 21 around 111 Thirst and the public understanding of that. And there was quite a lot of people that we spoke to that hadn't even seen some of the material. So I think the lesson from that is probably communications and the breadth of that communications to get that information out. And then we did a follow-up survey around experiences of using the 111 system in Devon and Somerset. Locally, we have done work with Beacon Medical around access in the Ivy Bridge and Plympton areas. It started off as concerns in Ivy Bridge, but working with Beacon and the clinical commissioning group, we widened that out. And I think the results from that has made it easier for patients to access, particularly using the telephone system, and waiting times have been reduced following some tweaks that they've made. We also undertook some mystery shopping work for Pathfields to have a look at their information they had on their websites, information that was outside of the surgery, and that was done back in April, May last year. So it was kind of when we were still in a sort of semi-lockdown position. But the report was accepted for that. And more recently, we've done some work around patient experience of children's services during COVID. And again, that covered the CAM service, special educational needs, learning disability, the Child Development Centre and paediatrics at Derriford. And again, whilst it was a small survey number, there was some very strong feedback within there about the challenges that patients were facing, and a lot of it laid with communication again. So I think you know, the big two themes from what we see is communication between services and patient, or communications more widely from NHS out to patients, and access to services. Moving forward this year, with things opening up, we're hoping to do more face-to-face engagement. So we've been kind of restricted to digital primarily. And I'm in consultation with Mayflower Medical Group at the moment around a patient survey for them, trying to understand, you know, from a patient perspective, what the issues are, how it's affecting them, so that can help feed in to the improvements that Live Well and Mayflower wish to put into place. So, you know, fingers crossed on that one. I think the other big point for me at the moment is, as I said right at the start, is patient confidence in being able to access services when they need it, and the information provided. I'm happy to take any questions.
Thank you. That's very useful, and certainly it's good to know that you're going to be able to open things up a little bit more. I probably need to just say a personal thing that as a patient of Mayflower Medical, it'll be interesting to see how they develop now with Live Well taking over. So thank you for that. Okay, questions? Right, let's start with the Vice Chair, then I'll work my way around.
Thank you, Chair. Reading on my computer about HealthWatch, I was very impressed about what you do. So I want to congratulate you on that. You know, it's obviously a link between service users and services. So that's good. What I want to ask is, how diverse are your volunteers? I mean, I read that you got one volunteer called Ola, is it, that speaks Polish, and obviously that's really good, because Polish is the second most common language after English. So obviously we need Polish-speaking volunteers. But yeah, how diverse are your volunteers, and what are you doing to get more volunteers and to retain them?
So I think during COVID, we've actually lost some volunteers because of the lockdown. Most of our volunteers in Plymouth were focused on face-to-face engagement, so that programme stopped. So we're kind of reinvigorating the volunteers that we're left with, but we've also identified we need to go out on a recruitment campaign to increase our volunteer pool. In terms of the equality, ethnicity type question and how diverse they are, I guess what you tend to find with volunteers, they tend to be either semi-retired or retired, so it's a particular age demographic. And unfortunately, we've lost some of the diverseness through our Plymouth volunteers. We had 3 volunteers from the sort of Muslim community, and they have moved on during the COVID period. So yeah, we've got some work to do on increasing the pool, but also the diversity of the volunteers in Plymouth.
Thank you.
Jemima.
Thank you. Yeah, I should declare I'm a patient at Mayflower Medical Group at Manmead Surgery. But I wanted to ask you about the consultation that's going on with the Mayflower Group particularly. I know it's happening because I saw it on HealthWatch's Facebook page. If you're not on Facebook, if you're older or, you know, just not on the internet particularly, how are you communicating that? And is there any, because one of the things I'll be feeding back is the wait on the phone to try to get an appointment. Is there any way of feeding into the messages that you receive while you're on hold that a HealthWatch survey is going on?
So I think the forthcoming work, it's co-produced and will be joint led between ourselves, Live Well Comms, and Mayflower Group itself, and we're looking at a wide range of how we can get the information out about this patient survey. So it won't just be digital, but they're looking at SMS text messaging, potentially a patient letter, that I believe what they're looking at doing is having a regular newsletter for patients as well. But I will feed back in those other concerns about how we get the information out. I would think it's going to be a couple of weeks before the survey launches anyway. The actual questionnaire is just being finalised at the moment, and then we need to sort out the final details of the comms campaign.
It just occurred to me that actually the people who are phoning up for appointments who might be experiencing frustration that they want to share with somebody are a kind of captive audience, and that will be the way that most people will be contacting the surgery. So if there was space amongst the plethora of announcements you get to say that that survey was taking place, I think that would be a really good way of encouraging people who might have some good things to say about the service, or if they've got something, a complaint or an issue that they want to raise. It's just a suggestion, and it seems that's the way most people who may not be online will be contacting the surgery.
No, I agree. It's a very good suggestion, and as I said, I'll feed that back into the team.
Of course, at the moment, they're doing patient engagement work throughout the surgeries. When I spoke to them on Monday, they'd already had 3 sessions, or Tuesday, I can't remember. Anyway, they'd had 3 sessions and were working to get ones with the other surgeries as well, so that's good. And they're looking to start up a patient participation group, which has got to be very useful, because we've not had one there for a long, long time, so that'll be useful. Thank you. George.
Thank you, Chair. I wasn't going to mention this, but I'm on Mayflower's books as well, and I was interested that they may be going to produce a newsletter. I think that would be very welcome, but I think even more welcome might be spending the money on an extra telephonist instead. I think the time taken to answer phones is quite appalling, and I'm not sure that could be improved somewhere. What I was going to ask was, does Healthwatch have a role in patient complaints processes? And if so, could Mr. Greaves tell us a bit about that, please?
So in terms of health watches, each local health watch is commissioned by its local authority. So there are some health watches within England that are tied in and deal with complaints. Health Watch in Devon, Plymouth and Tor Bay are not part of that process. So in terms of helping people with complaints, we do a signposting service to, and in Plymouth it's to the advocacy people who are commissioned to assist people as an advocate in making complaints.
Thanks, Chair.
Thank you. David.
Thank you, Chair. With respect to getting these appointments, the Beacon Medical Group itself, good results, so well done on that. Are you looking to expand this to other areas within the city and other groups? And if so, do you have a timescale on that one? I realise it may not be as contained as Beacon Medical, but okay, thank you.
I think our first sort of point that we always look at is what are patients saying to us. So if we're seeing lots of feedback about a particular service, that's when we start really taking interest and working out what it says and start having those initial conversations. So we've seen the feedback last year about Beacon. The feedback about Mayflower has been ongoing for a number of years now, and we've been working with the group trying to get improvements. I think there's a lot of reasons in the background of that why things haven't moved forward as certainly Healthwatch would have liked. But I would also say there are some good GP surgeries in Plymouth. You know, we don't hear about them, but and because of their anonymity in patient experience, then you know it's kind of you know things, they must be doing something right if people aren't coming and talking about them. So where we are at the moment, given the resources we've got, also with the integrated care system, the pull on us now from the white paper to support that and be part of that. I would think, you know, patient experience and the majority of patient experience will lead us into our engagement work moving forward. So we don't have a particular programme around moving from one GP group to another. However, we are monitoring it.
One of the things that you've done is obviously the survey of who turns up at EDs and whatever, and that's been very, very informative. As we're moving forward, would you be looking at repeating that to see if any of the reasons for going to ED change because some of the COVID restrictions perhaps are being lifted, the GPs are seeing more people face to face? Will that be something that you think about looking at again?
I think from a health watch perspective, it would be useful to repeat that at some stage. But as that piece of engagement was sort of done in co-production with what was then the clinical commissioning group, I think we need to take it up with them. And it wouldn't surprise me if we didn't go back in as a follow-up at some stage, though.
I think, folks, that might be something that we could help forward as a recommendation from us, that it would be a good piece of work and valuable information gained. Lee.
Yeah, I just would like to say thank you, Tony, for a very comprehensive piece of work, in parts extremely damning. However, the emphasis on what the end user, the patients, basically have to say is extremely pertinent in all surveys. Now, we know from previous services, for example, there was a conflict between the CCG and Mayflower Group over the Collins Park closure. And I bring to you a point that the actual survey was appalling. The electronic means failed, and therefore the result was clearly unambiguous, or ambiguous, shall we say, not unambiguous, which led to the Man and Mead surgery being overloaded with patients and therefore falling into a state of flux, shall we say. Now, I visited the Man and Mead surgery the other day to find out that the 4 surgeries in this group only had 2 GPs operating, whereas previously you would go to Collins Park, they would have 2, Man and Mead, you would go and have 4 GPs. So I think there are questions that would need to be looked at with regard to GPs. Where are they, and why are they not in there seeing patients? And I wonder whether that could form part of the survey. But like I said, most importantly is to look at the means of communication to the key stakeholders, whether it be by survey, whether it be by notices, whether it be on the web or whatever, to make sure it is a very comprehensive survey that truly reflects on what the patient has to say. Thank you.
Can I just say we've got primary care on the work programme, probably for the September meeting. So therefore we'll be able to look into all of those questions you're asking there, because obviously it's not just one particular surgery, it's all surgeries in Plymouth are having concerns about getting workforce, whether it's doctors, whether it's nurses, etc. So we'll be able to really delve into that next time, Lee. All right, so that, just bear that in mind. Yeah.
Can I just say the comments were purely in reflection of what Tony said about the Health Watch survey into the Mayflower Group specifically. Thank you, Chair.
Any more questions for Tony? No? Okay. Yeah. Are you all in agreement that we make a recommendation to redo the survey into ED at an appropriate time? And I think that I'd probably like to talk with Tony to find out when that is the right time to do it. But I think if we certainly should be looking at that. Are you all happy with that? Yep. Thank you, folks. Tony, thank you very much. You're obviously welcome to stay because there's lots of interesting bits and pieces on this afternoon's agenda. But I accept that you may have something else you need to go in and deal with. But thank you very much for coming. And please thank all your volunteers for all the work they do on our behalf. It was quite interesting to look through your brochure, because there's obviously people that we've known for many, many, many years, and they're still with you, and that's got to be good. So thank you very much, and send our regards to them. Thanks.
Thank you, Chair.
Right, folks. Okay. I feel remiss because we've not really introduced our cabinet member who has joined us today. Thank you very much, John, for doing so. I don't know if you want a couple of minutes before we go on to the next item to say anything of pertinence that you think ought to be said.
I would like to say a few words. Thank you, Chair. I'd like to say a few words about this item, but more generally, perhaps I'd just like to thank the staff who are managing the social care system very well in Plymouth. I think, you know, the backlog is not too great for people waiting to come out of hospital. Very stretched resources in domiciliary care. I mean, it is always a problem. It's probably worse at the moment with the employment crisis that we have post-pandemic, but I know the team are working valiantly to keep the service on the road for older people at home, and also for those who need care in homes, so which helps, of course, reduce the pressure on the hospital. So a great tribute to them, I think. Plans are going well with the West End hub, hopefully, which will be a great asset to the city when it opens, hopefully in 18 months, 2 years or whatever. So I think that's about all I want to say about the portfolio generally, but I would just like to say a few words to introduce this topic. Are you happy I should do that?
Do we need to do a chair move around first, or would you, if you say your words and then we'll do the chair move around? I think that's probably the easiest. John, the floor is yours.
Thank you again, Chair. This topic, I think, is very critical at the moment. I'm sure we all have heard during the pandemic, and particularly post-pandemic, about issues increasingly of people accessing urgent and emergency care. The impact this is having on A&E, the impact it's having on the ambulance service who can't unload their patients because of the numbers in A&E. We're not here to discuss primary care primarily today, but I think it is because some people are having difficulty accessing non-urgent primary care that they then resort to going into the churn of sort of 111 or out of hours care, and the whole thing becomes circular, and you actually have people who are not as acutely ill competing with people who are acutely ill, and the problems are then that this impacts badly on A&E and particularly the ambulance service. I mean, I've heard all sorts of things, as I'm sure we all have, from patients. I've also heard it from people who work in the health service in different areas. You know, there are huge pressures, but I think some of the problem is because patients aren't actually going through the correct pathways because they seem unable to access the care they need, and then it all becomes a scramble to get some sort of service from wherever you can. So I hope we're going to have an open, frank and transparent discussion this afternoon about all the issues involved, and then we will hopefully support any recommendations that are made. We now have the new ICS system running. So I think now is the time for more collaborative working, and if there is a chance to sort out this issue, which seems to be particularly pertinent in Plymouth, then now is the time to do it. So thank you to everyone who's come along, going to contribute, and to the discussion that we will have. Thank you.
Thank you. Anna?
Thank you, Chair. So I think, as Councillor Mahoney's alluded, you know, clearly significant amount of challenges across the whole system, and welcome some time with the committee this afternoon. The slide packs clearly come out, and what we've endeavoured to do is to give absolute visibility across performance in a range of areas across the urgent and emergency care system, but also to describe some of the improvement work that is underway. And you know, very much looking forward to a healthy session this afternoon in that respect. Delighted that, you know, joined by a lot of colleagues in the room today, and I think thank you for that, because I think, you know, colleagues across the system under a lot of pressure, but clearly understand the importance of being here with you this afternoon. So I'm not going to take any more time. We'll do a little bit of chair moving around. We think it would be helpful maybe to take the material in sections. So I think colleagues will join provide some information in terms of performance, illustrate to you some of the areas of improvement and some of the challenges that exist in a very open and transparent way. And then we'll move on to, then there's time for questions, Chair, and then move on to the next session, because otherwise I think we'd fill the room in terms of, but I think probably colleagues will see the complexity of the world of urgent and emergency care as we go through the session this afternoon. Thank you, Chair.
Thanks very much. And I certainly think with the paperwork that we've got, is some of the print is quite small for a lot of us who have sight challenges. So I think there may well be a fair number of questions sort of asking for teasing out as to what X or Y says. So you're in charge of the organisation for the seating, Anna. That's great.
I'm clearly developing hostess with the Moses, Chair.
Well, exactly.
The first section on the slides, I'm also operating the slides, so this is going to go well. So the first section this afternoon, we thought it would be helpful to share with committee the work in relation to integrated urgent care, the 111 service and out of hours general practice. So delighted to welcome Dr. Daffyd Jones and also Jo Turl, who's on our screen. So Jo Turl is Director of Commissioning for NHS Devon with lead responsibilities around out of hospital provision. We'd hope to be joined this afternoon by Justin Geddes, who is the Chief Executive of Devon Doctors, but unfortunately, Chair, he has sent his apologies. So I'll hand over to Jo and Daff to take us through the first slides.
Lovely, thank you, Anna. And if you can just give me a thumbs up so that I can tell that you can hear me in the room. Brilliant, excellent. Thank you for the thumbs up. So as Anna said, just to introduce myself, so Jo Turl, Director of Commissioning for NHS Devon. So that covers primary, community services, children's and mental health as well. A couple of things I want to say before I go into the slides. So first of all, apologies, I can't be in the room with you this afternoon. I was planning to be, but unfortunately I got COVID last week and is still testing positive, unfortunately, or else I would have been there with you. So I apologise for that. Also, I will be back in September as well for the primary care sessions. Obviously noted some of the comments that were made earlier on about primary care and some of those concerns. So of course, having heard some of those, I can take them back in preparation for September. And also wanted to recognise the work that Health Watch are undertaken, and Tony in particular in working with us, and just to assure the committee the information, particularly the information that we got from the surveys in ED, but also from general practice as well, have very much gone into the primary care strategy, the general practice strategy that we'll be bringing in September. So just to assure you that information has been used. I'm very happy to have a discussion about those issues then. So first thing I think I want to say, also obviously unfortunately Justin can't be here, but I'm very happy to take us through where we are with the current service and future plans. And obviously, as you know, Daffyd is in the room as well, and I'm sure can take any clinical questions that you might have. But I think the first thing that I want to say, and I'd be remiss if I didn't say this, was to recognise that this service isn't where we want to be at the moment. I think we've heard from Health Watch. We've seen the report that they've undertaken, and people in the room will have some individual and personal stories, and I know some of those stories, and I've spoken to individuals as well who've experienced the service over the last few months. And I think, and if Justin was here, he would do the same. But I think there is a need to just want to publicly say that this is not where it needs to be. And the plans that we have in place, I hope and I know, will make sure that we have an improved service moving forward. But I'm going to take you through now just the service itself for those people who aren't as close to the service, and what some of the current issues are. And then very much I will focus on where we plan to see improvements and what we're doing as a health system in order to make sure that happens. So the service we're talking about is the Integrated Urgent Care Service. So it's a nationally, there's a national specification for this service. but it is commissioned locally, so each individual ICS commissions this service. Devon Doctors currently hold the contract for the service and provide that service, and will continue to do so up until the end of September. The service includes the 111 call handling service, the clinical assessment service, and also the GP out of hours provision in Devon. So 111 performance at the moment. So as I've said, this service is by no means performing as well as it needs to at the moment. And certainly if you look at services nationally, I think nowhere in the country is performing as it needs to. But I think if you look at our area in particular, there is absolutely a need to make some improvements to the quality of the service. So hopefully you'll have had a chance to look at this, but I'll just explain that graph on the slide. So the red line is the calls answered within 60 seconds. This is just a measure of how quickly people are getting through on the phone. And as you can see, there's a national target of 95%. Back in December 20, Devon Doctors were achieving over 80% of calls being answered in 60 seconds. And as you can see at the moment, that's hovering around just over the 40% mark, which isn't anywhere near as high as it needs to be. The blue line there is the number of calls that are abandoned within 30 seconds. That's people who phone up but actually choose not to wait because they've been waiting too long for the phone to be answered. And as you can see, we had a relatively low abandonment rate at the end of December 20. So it's less than 10%, so it's very good. And as you can see now, we're hovering around the sort of 35–40% mark. So again, nowhere near in terms of where it needs to be. In terms of just describing, I think, why we are where we are, and some of these things won't be unfamiliar to other parts of the health and social care system, but also won't be unfamiliar to other sectors as well, locally and nationally. So they've got a significant level of unplanned absence in Devon Doctors, and as you can see from the last bullet point on there, that's particularly become a driver over the last few weeks and months with COVID, and again probably expect over these last couple of weeks and the next few weeks to see that increase as well. Insufficient weekend establishments. This is people taking up shifts perhaps during the week where some of those shifts are more palatable for people, and not wanting to undertake some of those weekend shifts maybe where people are less inclined to do so. So we do have a general underlying issue that establishment at the weekend isn't as high as it needs to be. I do have absolute confidence though, and know from the meetings that we have with Devon Doctors that they continue to recruit and put a lot of effort into current recruitment. But we are experiencing real difficulties recruiting into this market in this particular staffing group. As I said, that isn't something that's just being seen for the health service or 111 in particular, but it is an issue nonetheless. Devon Doctors continue to put on staff training sessions, but again do appear to be blighted by high dropout rates. That's people that have accepted a job at Devon Doctors as a 111 call handler, but then don't continue to go through the training. There are some on the next slide. There are some other key performance areas as well that I think are important just to mention. So not some of the ones that are kind of national targets, but are other important areas. So I am pleased to say that those people who need to be seen face to face, either in a treatment centre or at home, generally get seen within the clinical time that's appropriate. So about 75 to 85% of people get seen within that time. So we're not hitting that 95%, but it has been pretty static. It's reduced a bit over the last couple of years, but Devon Doctors are maintaining that level of face-to-face care. And on the next slide, so a few things I think worth mentioning. So an area I think is really positive is that this isn't just about call answering, but is very much about where patients are signposted to. Something that Devon Doctors do very well and have always done very well is the validation of those patients and the pathways that those patients are put on ultimately. And in doing that clinical validation, they are able to validate people away from both 999 and ED, and they have exceptionally high rates of doing that. So when the call does get answered and those calls are clinically triaged, actually Devon doctors have got very good performance in terms of making sure people go to the right places and aren't unnecessarily sent to ED or to 999 either. I think just in terms of noting some other things, I think particularly around safety. So during periods of high demand, Devon doctors undertake patient safety calling. So call handlers will recontact patients who are waiting just to check that they're okay. And they do give them extensive advice on what happens if their condition would worsen as well if they are waiting for a call back. So there are some sort of fail safes that are in place there as well. Next slide.
Joe, before we move on to the next slide,
yes,
can I just ask you to explain what IUCS is? We've
yes,
got a lot of anachronisms in here, and I think we really, a recommendation must go that we need to get a better list of all of these. All right, sorry.
Yeah, no, please don't apologise. We should have made sure there weren't acronyms within the presentation. So the IUCS is the Integrated Urgent Care Service. So it's that all-encompassing service of 111, the clinical assessment service, and also the out-of-hours GP service as well. So, but please do say if I go into fall into the trap of acronyms. Do just want to talk about contingency planning, because as I've said, the service isn't where it needs to be at the moment. We have had to fall back on contingency plans to make sure we have a safe service that is delivering up to a certain level of quality as well. So if call handling performance or the level of clinical triage levels that we have reach a clinical point, national contingency is used. So that's a national pool of call handlers and clinicians which we can invoke, which will then take calls on behalf of Devon doctors. We can request that when a service is under pressure, but given, as I've said, the pressure over the recent weeks and months, we have done that on a planned basis. And expectation is that we continue to do that for certainly in the short term, albeit we have some other contingency plans in place, which I will talk about a little in a moment as well. So just on to the next slide. So just in terms of what we're doing to currently manage that contract, and then I will talk about future arrangements and why I believe this service will improve. We have monthly contract management meetings where we review in detail. We go through activity data, we go through performance data, we go through workforce data. We also review any trends in serious incidents and monitor complaints and friends and family testing. So we do get that information, not at an individual patient level, but an overall level, so that we can monitor trends and we can work with the provider and understand what their action plans are in relation to these areas. We also have twice weekly operational meetings as well, where we get into granular detail, I think more than we do for any other provider, around rota fill, sickness levels. So we really do, and we do this on a Tuesday and a Thursday going into the weekend, to make sure that we're working with the provider and we're all doing as much as we can possibly do to make sure that we've got adequate coverage, particularly going into the weekend. Okay, and yes, so I think this is the most important bit, is what we're doing, and there's a kind of medium to long term, and then there's a very short term. So I'll just talk about the medium to long term for a moment, because ultimately this is the bit that will make the biggest difference. So we made a decision as then NHS Devon CCG the beginning of last year, the service was not delivering the quality of service that it needed to do for the population, for lots of reasons, and I have talked about some of those reasons here before at prior scrutinies. And the governing body made a decision that we needed to go out to procure the service. We wanted to make sure that we undertook significant engagement with both the public, users of the service, friends and family, and also providers. that are out there and already providing this service in other parts of the country to really understand how we could commission a better service moving forward. So we undertook significant amount of market engagement and testing, and undertook a lot of work on clinical pathways to make sure that although we've got national specification, that the clinical pathways that we have in place locally are the right ones, and make sure that we can make sure that patients go to the right place. So after undertaking extensive procurement, we've awarded the contract to Practice Plus Urgent Care Group Limited, as I know you know, and I've said here at Scrutiny before. I'm really pleased about that because PPG are rated as an outstanding service for some of their 111 services. They're one of the largest providers of integrated urgent care services nationally. Their Bristol service, which is rated as outstanding, is one of the services and one of the call centres we will be using locally. So we will still have local call centres, but also we will be very much using that Bristol call centre as well. And what that means is there's a lot more strength in terms of resilience, and an organisation like PPG obviously being able to use services from other parts of the country at times when demand is high. As I said, they're one of the largest providers of integrated care services, but they are also the largest independent sector provider. Obviously have a base in Plymouth as well, which I'm sure many of you will know. And they operate 4 111 contact centres, 4 clinical assessment services and 7 out-of-hours contracts as well. So we're very confident that they will deliver a better service. And really it's been the focus of our team over the last 9 months to make sure we've had a really good process and now a really strong mobilisation period as well, working with PPG to make sure that we've got a good service to go live on the 1st of October. That's last slide, but what I also do want to just talk about is what we're doing in the short term as well, because I think it's really important that although absolutely we have to focus our energies on that medium to long term solution, because it's imperative that we get that right, I have said and recognised that we can't continue with the level of service that we've currently got. So there are a few things that we're doing at the moment, and these are very much live actions, so hence why they're not on the slide. I think the first thing that I want to say is that we're working very closely with Devon doctors. As I said, we meet with them twice a week, and we are exploring what more we can do, whether that's local incentives for clinicians, or how we can help and support them with recruitment to make sure that we can increase the shift fill. I am really pleased to say that the mobilisation with Practice Plus Group is going really well, and they're working very closely with Devon doctors. And in fact, just this week, we have agreed that Practice Plus Group will take on the management of the 111 service early. So instead of taking on the management of that on the 1st of October, they will do that from next week. So I really hope that that will mean that we've got the weight of PPG behind us in terms of the delivery, the management and the oversight of that service, but also that will enable them to start recruiting 111 call handlers. And we really think that both with their ethos to staffing, their training that they put on for staffing, and also the I think the certainty that they can give to staff as well about future career, that we really think that will help in terms of both recruitment and sustainability in terms of workforce as well. We also continue, as I said, to work with Devon doctors, and we'll continue to work with PPG as well around some additional short-term measures that we hope to put in place. And I'm very happy to sort of update outside of Scrutiny as soon as they come to fruition over the next few weeks. I'll be able to be a lot clearer about what that is. But I do want to assure you that this is something that we're taking really seriously. And I think we've got some good mitigations in place, and I do believe we will have a better service from October. But as I've said, we haven't given up on making sure that we improve services over these next coming weeks and months as well. But I'm very happy to take any questions, and as I said, I've got Daffyd in the room as well, so if there are any particular clinical questions as well, I'm sure Daffyd will be able to help.
Daffyd, did you want to say anything before we move on to questions?
No, I think Joe's covered everything really. I think what I would echo is saying, as a citizen in this city, the current position, I would absolutely echo what Joe has said. The current position is not acceptable moving forward. I would echo Joe's points around, I think the measures that are being put in place, I have significant confidence and a very clear expectation that things will improve significantly. and I could talk quite extensively about that, but I'm sure there'll be some specific questions that I'll answer as they arise. Thank you.
Thank you very much indeed. Right, Vice Chair.
Thank you very much, Chair. I welcome PPG taking over from Devon Doctors. One of my mother roles is that I'm a staff nurse working at a nursing home. And unfortunately, there's been instances where over the weekend, I've asked Devon Doctors to send out a doctor for one of my residents, and then been able to do so because candidly they said that there's only been one doctor available, and one particular case that was based in Newton Abbot. So hopefully going forward, PPG will improve matters, and we're all here for the residents and in particular my patients. So yeah, so I really welcome the change.
Thank you. Lee.
Hi there, Chair. I think this is directed at Joe. Devon Doctors in special measures. What has been done to bring them out of the CQC measures, considering the reliance you are putting on them? Question 1. With regard to performance indicators, I can speak personally, 14 hours for a reconnect and over 60 minutes to get through. That was on the 1st of June 2022 this year. And it's been 5 years since it's been noted by the public and stakeholders that the service has fallen quite badly. What can you say to actually assure us that this 5 years is at an end and this is a new chapter in your existence? Thank you.
Chair, would you like me to respond to that one?
Yes, please.
Yeah, thank you. Yeah, thank you very much for your questions, Councillor. I think that's kind of part of the same question, but I think there's something about what have we done as a commissioner to support Devon Doctors through this difficult period, and then what confidence can we give that things are going to get better. So I think in terms of how we've been working with Devon Doctors over the last few years and as you say, over a significant period, I think we've done several things. We've always worked really closely with Devon Doctors and we've always had a very good relationship. So right before even the integrated urgent care service came into being, Devon Doctors provided really good out of hours service, and I think most people would say that. They started to come into some difficulty with taking on the 111 element of the service, and I think they would probably recognise that was true, and it was a different area for them to go into. So what we did is we put additional resources into working with Devon Doctors, and in fact we supported and paid for resources to actually help support and manage the service for them. So we did that over a period, and we have seen some improvements, and we've seen some improvements in action plan, particularly around some of the areas that the CQC highlighted. And we worked with them when we were meeting with Devon Doctors on a weekly basis to review that action plan in conjunction with the CQC as well. And as I said, that did lead to some improvements, but it just wasn't enough really to deliver the kind of performance and quality of service that we wanted to see. So I think, I'm very confident if Justin was here, he would say we've worked closely, worked collaboratively. We've worked very closely with primary care, general practice, to really encourage GPs to come and work in the service. We've really encouraged and helped support their recruitment as well. So delivering and working with them on some of those recruitment campaigns. But as I said, it just wasn't enough in the end. And I think the sustainability of having a large scale provider like PPG who can utilise the different services and the different call centres that they've got around the patch, I think will enable a much more sustainable service. And I think that's the big difference for me, is we're going for something that's very local, and I think we're all supportive for, and wanted Devon Doctors to succeed in that. but to a provider that I think's got a lot of experience or has got a lot of experience in this area and can really lend some of that experience, that structure, that governance, but also just really critical mass that will enable things to be different from October.
Thank you, Jo. Jemima.
Thank you, Chair. My most recent experience of ringing 111 was at a weekend. I was cut off twice after being on hold for 40 minutes and 46 minutes, then on hold for an hour and 16 minutes before the call was answered. So I've got two questions. One, you've got data around the caller hanging up. Do you have data around the system cutting callers off? And the second question is how the new PPG contract is going to address the insufficient weekend establishment issue that you talked about. Thank you.
Yeah, thank you very much for the question, Councillor, and I'm really sorry that you had a poor experience. I can only apologise for that. You're absolutely right, we do get data in terms of abandonment rates. That's the first time that someone's raised with me that they've been cut off. I can honestly say that I've not heard that, I've not seen that personally in any sort of correspondence or complaints. So I'm really interested to hear that. I think if and I encourage everyone else to do the same as well, and if you hear that from any of your constituents, if people are finding that that is a problem and that is an issue, please let us know. I think it's much more helpful if I can have some specifics, and you've obviously got some very specific times in that, Councillor. So if it is possible to contact me outside of here and give me that's information that we can follow up. So I'm surprised to hear that, but if that's happening, we need to deal with that. In terms of the new contract, I think there's several things that I would say. PPG have got a really good, strong track record, and hence why they were selected through the procurement. And I should say that we had a lot of interest. So we had a significant amount of providers who joined us for the market engagement, and we also had significant number of national providers who put in a bid as well. So actually, it was quite a hard decision, and we believe we chose though the best provider. And PPG have a really good, strong track record of being able to deliver really good performance. So they have a good reputation as an employer. They have a good reputation around their training, and we're already hearing from sort of early people who are starting to kind of be employed through that route, that the training program that they've got set up is really good in terms of encouraging, really creating a good ethos for staff. And one of the issues is not only at the moment just being able to recruit, but it is about retaining staff even through that training period. And the early signs are that that is really positive, and people are going through the completion of the training, and that's a really positive thing. They've also undertaken quite a bit of engagement so far, though they plan to do a lot more with local clinicians as well. And again, they've got a really good, strong track record of working with local clinicians and working with local systems and being part of ICS, being at the table. So again, I've got a good degree of confidence that they will encourage local people that have either already worked for the out of hours service or might have worked in the past but have chosen not to recently, or maybe have never done that, but that they will encourage people in. And of course, the more people that we can get on the books, either call handlers or clinicians, that will really improve that weekend rotoring. And then the last thing to say, and I know I've said this before, but it is really important as well, is them being a big provider. It does mean at the weekends they will be able to call on some of their big call centres like Bristol, for example, which means we would hope to see that their establishment at the weekends is much better than what we've currently got as well. I can't see David from where I am. I can just see myself, actually, unfortunately. But I don't know, David, whether you did want to say anything else about PPG and their kind of approach to working with local clinicians.
Yeah, thanks, Jo. Apologies, I didn't introduce myself at the beginning. So I'm David Jones. I am a GP in Plymouth. I also work for NHS Devon as well. And as mentioned earlier, myself and my wife and my daughter and my in-laws live in the city. So absolutely, what happens in health and social care in the city of Plymouth is fundamentally important to me in many, many spheres of my life. So I think what I would absolutely echo is one of the challenges and one of the themes that you're going to hear that cross-cut a number of areas today, speaking absolutely candidly, is the balance between demand and capacity. So there's a lot in the national press, local press around workforce, and those issues are particularly significant in this city, whether we talk about GP numbers, rota fill in emergency departments, domiciliary care workers, etc. So there are some things that we can control locally, and I'm going to talk about those now. And there are other things that are being played out today. I believe there's a parliamentary discussion regarding GPs and consultants and recruitment, which perhaps we'll come on to in a moment. I think the question is how do you maximise your existing workforce? So there's a lot being played out around workforce strategies, absence of workforce strategies. You do not generate a workforce in a day, a week, a month, a year, or even several years. But what can you do to maximise your existing workforce? So what can you do to bring people back that may well no longer do out of hours, for example? And how do you look creatively at the workforce that you've got? I meet on a regular basis every couple of weeks with the medical director for PPG, the organisation who will be running this, and I absolutely have, I really get a feel that they have a number of really creative solutions and approaches to this. So as Joe has already mentioned, they are tried and tested, they work in a number of other areas of the country. I'm not saying that they are the same, exactly the same as here, but they have tried and tested a number of approaches to recruit, because there is a national context to this, albeit Plymouth is particularly challenged in this space, and that will be a theme that comes out, and I think it would be really good to see some practical recommendations that come around what is within our gift to either lobby nationally around those type of issues, around what we can do to maximise our workforce. But some creative solutions around human resources, around employment arrangements, remote working, flexible hours. These are all things that are approaches that have worked and been able to recruit additional numbers. Councillor colleagues mentioning earlier about working in a nursing home, and there being one doctor across Devon. So how much of an impact those will have remains to be seen. However, the scale of PPG as an organisation, their ability to flex their both non-clinical workforce. So this only works if someone answers the phone. It was mentioned earlier, 42 minutes, 46 minutes. Whatever you do with your clinical workforce behind that is immaterial if people aren't answering the phones. So there is an approach and a flexibility that I have confidence will improve things. And I believe improve things significantly. But behind that, clearly, we need to have a clinical workforce. Doctors, nurses, paramedics and others to be providing advice and guidance, professional advice and guidance. So I'm confident that that approach, there are also really good systems in place in terms of, I really get a feel for a learning organisation. So again, the term audit gets, well, what do we mean by that? But actually, I've linked my colleague from PPG, the medical director, with colleagues from Derriford Hospital, a number of around creating a feedback loop from either events that have gone where there's been the wrong pathway or someone's ended up somewhere where there's perhaps some learning from or a complaint or what have you. So there are examples, number of examples in other places where they run, where they learn continuously from that. I appreciate you'll want to hear specific examples. I'll probably stop at that point, but I think what I have confidence in is the things that are within the local gift to maximise the workforce that we've got are being taken. There are some things right across health and social care being debated at a national level around how we maximise our existing workforce, which has to sit as a key part of our short-term plan alongside what is the workforce strategy across health and social care over the medium and longer term. Those two things need to sit side by side.
Thank you very much indeed for that. And I think this committee will be very much wanting to see how the next 6 months go, in particular with the sort of taking over the contract there. And I think that's probably essential. That one of our recommendations will be that we would like to invite you back to a meeting we'll work out when it'll be Joe and David and let you know. And obviously it'd be good to meet the people from PPG at the same time, so that would be useful. Okay, folks, now I'm going to call a break now. We need 10 minutes, please, folks, just to ventilate the room a little bit because it's getting quite hot and stuffy in here. And I don't want any of you falling asleep, all right, because it'll be on camera and that would be dreadful. Okay, so I make it just gone 10 past up there, so just gone 20 past. All right, see you then. Patrick, welcome. Okay, folks, can we get settled, please? Right, we'll now move on to the next item, which is, according to me, ambulance handovers. If you would like to introduce yourselves, that would be really useful. Thank you.
Okay, good afternoon, everybody. My name's Davy Harper, and I'm the County Commander for South West Devon.
Hello, I'm James Glanville. I'm Head of Urgent and Emergency Care for NHS Devon. I'd also like to introduce James Wenman, who's on screen with us, so I'll let him do that.
Thank you, James. Good afternoon, everybody. My name is James Wenman. I'm the Associate Director for Urgent Care and Ambulance Handover Performance. It's in my portfolio.
Thank you. And Joe, are you coming up to the table here, or can we squeeze you in somehow? And if you'd like to introduce yourself.
Hello, I'm Jo Beer. I'm the Chief Operating Officer at Derriford Hospital.
Welcome, everybody. Thank you. So, who's going to start?
Okay, if everybody's quite happy, I'll start. Okay, if I could just provide a quick overview of the data that I'm going to present today. If I give an overview of the SWAS footprint, we cover 7 CCG areas. I would generally present data at a CCG level. Within the footprint, there's actually 8 counties, with Devon being the anomaly. There's 2 counties within the Devon CCG locality, and that's split into North and East Devon and South and West Devon. As such, the data that I'm going to present today has been filtered down to a county level, and it's been filtered down to South West Devon, as that'll allow me to present a better local operating picture. So the data will cover everything from Dawlish down through Torbay into the South Hams, into Plymouth and up to Tavistock. Okay, what I'm going to start with here is the first slide, and this shows 999 call demand compared to the number of ambulances conveyed. Ambulance activity in South West Devon saw a substantial increase last summer, rising to over 400 incidents a day, and that was unprecedented. Since then, ambulance activity has returned to more normal levels. In April this year, we saw an average of 335, and then in May, we saw an average of 333. So that's very similar to the levels of activity that we witnessed in 2019 and 2020. And the reason that's important at the moment is I'm just highlighting that we don't see activity as being a major factor driving our increased response times at the moment within South West Devon. Recently, as a trust, we've been managing approximately 65% of our patients without the need for conveyance to emergency departments. Pre-COVID, that figure was closer to 52%, and we're continuing to work with the health community, the wider health community, to manage patients outside ED when clinically appropriate. If I could just move on to the next slide, please. Excellent, thank you. What I'm going to cover off here now is ambulance response times, because I know it's a hot topic. I'm going to cover off our Category 1 calls, and Category 1 calls are those incidents that are classified as life-threatening injuries and illnesses. So that covers things like cardiac arrests and anaphylaxis. The ambulance response programme sets ambulance services a mean target of 7 minutes for attending these incidents, and it accounts for 15% of ambulance responses. The top graph here shows a correlation between the increase in Category 1 response times and the increased time lost to handovers. In April 2021, when handover delays were lower, we had a Cat 1 mean time within South West Devon just under 7 minutes. In recent weeks into June 2022, our Category 1 response times have been in excess of 10 minutes. And the columns in that top graph there represent the amount of time lost at each acute. What I have to highlight here is to clarify the data. When I'm looking at the response times, that's specific to South West Devon as a county. But when we look at the time lost to acutes, that covers all patients. So when you start looking at Derriford ED, that'll be patients that are coming in from East Cornwall into Derriford, or any patients brought into specialist pathways. But it's evident here that as we've seen the increase, as evidence there, that as the delays have increased, also our response times have increased sharply. And it's even more evident when we move on to the next slide and we look at our Category 2 responses. Okay, if I just clarify, Category 2 calls are those calls classified as an emergency or potentially serious condition that requires a rapid assessment. So that covers incidents like stroke, difficulty breathing and chest pain. And the ambulance response programme has set a target for 18 minutes, and that accounts for 60% of the ambulance responses. If we go back to April 2021, the Category 2 mean time within South West Devon was approximately 25 minutes. And recent times, we've seen that increase to over 2 hours. Well, the average handover time at some acutes now exceeding 3 hours. This is limiting the number of patients that crews can see in an 11-hour shift. The job cycle for conveyed patients can now take up to 4 or 4.5 hours. This means that when we're putting additional resources on, we're not seeing the productivity we would have hoped to see. The number of patients with very long response times was over 25% of patients in March received a Category 2 response time of over 2 hours. If I can just move on to the next slide, please. This slide provides a 28-day snapshot of ambulances sat waiting for handover at hospitals. It doesn't present the maximum number of resources, it presents the average, but I think it highlights the regular challenge with 20 or more operational responses being held outside hospitals at the most challenging time. It's quite evident here that the peak times are later in the day, impacting SWAS's ability to respond into the evening and overnight. And I'll just move on to the final slide, please. We've tried to provide a heat map here showing the Category 2 response times between the 25th of April and the 5th of June over a 6-week period within South West Devon as a whole. The darkest red area here highlights that they're getting a Category 2 response time in excess of 1 hour and 20 minutes across 141 incidents, and that's the PL19 area. That's up towards Tavistock. There are 5 other areas within this map where we're having a Category 2 response time of between 70 and 80 minutes, and that covers the postcode areas PL1, 2, 5, 8 and 9. Historically, as a trust, we would usually expect to see much better response times in heavily urban areas. But what I'll do now, if I can come to James Wenman now to cover off the next slide, please.
Thank you. So James Granville might also contribute to this discussion. So it's fair to say that and quite rightly, ambulance handover improvement is consuming a significant amount of time and focus. There are a number of plans held across Devon that we have spent a large amount of our time consolidating into understanding what actions do we think will be impactful, first and foremost, in that we'll get a good return on any investment of time, resource and capacity, and also understanding what is the role perhaps of stakeholders in terms of improving their own services under sort of business as usual measures. As you can see from this slide, there are a number of areas in which we are focusing on, and we have taken learning from across Devon to ensure that where we have actions that have resulted in demonstrable improvements, we are scaling those where possible. There is also, I think it's fair to say, a significant amount of attention nationally. There was a recent meeting and challenge put to the Devon system, and particularly to West Devon, to reduce ambulance handover delays, to have a zero tolerance approach to ambulance handover delays that exceed 30 minutes. That challenge was put to us by the National Director of Urgent Care, Pauline Phillips, and Stephen Powis, the National Medical Director. Other colleagues in the room, so Joe, myself, Kath, and ambulance colleagues are working this week to understand what improvement activity we can, I suppose, plan to ensure that we meet that challenge and respond to the national team by the early part of next week. James, is there anything you wanted to pick up in specific to the local plans that you own?
A lot of our emphasis is around the same day emergency care offer, but I'm not going to cover that because Jo's going to talk to that later in her slide. I guess from my perspective, it is a huge area of concern for us as a system. Colleagues in Cornwall have also been given the same directive around ambulance handovers. And we do take a lot of ambulances from the Cornwall area. So from East Cornwall, we will have ambulances arriving at the Acute Trust in Plymouth and also in Torbay. So in terms of mutual aid, what we're quite often unable to do is to look for mutual aid from our partners. I guess the other thing I would say around this ambulance handover plan that we're looking at, there is a huge amount of interdependencies with this. The flow coming into the hospital and the flow coming out of the hospital all have a huge impact. I'm sure there'll be lots of questions, and I'm sure lots of people in the room have been affected by the current position that we're in. Thank you.
Okay, anybody? Joe, did you want to come in and say anything at all here? That's lovely, thanks. Okay. Sorry, do you mind?
Thank you. As I think most people in this room know, I've had experience of being with a Category 2 patient who should have had an ambulance within 18 minutes, and it didn't come for 6 hours. And it was an extraordinarily distressing experience, both for me and I think also for the call handlers and also for the paramedics when they turned up. And none of this discourse is meant to be a criticism of those people at all. I think that the care, speaking from personal experience, that my father got each leg of the way was really good. It was the pathway to getting that care, which seems to me to be pretty much broken. And it's all well and good for whoever it was who said, Pauline Phillips, to talk about zero tolerance. But I'm visiting my father in Derriford every day, and I'm driving past a fleet of ambulances at the moment, all with their doors open because it's sweltering weather. So one of the things that I wanted to ask was, we know that the Healthcare Safety Investigation Branch have talked about moving from talking about risk to harm. So I wondered whose job it is to be calculating that harm. How many people in Plymouth are dying because of this ambulance delay situation? Whose job is that to work that out? And how are they making that calculation?
Okay, so in terms of that as a system, obviously that we have interdependencies with our colleagues in SWAST, and all incidents are captured and run through, particularly for learning. So we hold that information at a system level. I think as a system, we are really challenged, and COVID has peaked and is starting to peak again, and we are finding that staffing levels are really insufficient on the ground in a number of key areas. And then the decisions that have to be made are risk-based decisions across organisations. So on a daily basis within NHS Devon, there are system calls, which Joe, others, all of the people in this room are party to, and with colleagues from across the rest of the Devon footprint and indeed Cornwall, where on a daily basis we have a whole host of information around performance and we have to make risk-based decisions. I don't know if, James, you wanted to add anything to that as well?
Yeah, thank you. So a wholly appropriate question, Councillor, and one that we're acutely aware of, in particular the HSIB report and the Ambulance Association Chief Executive's harm report that was published in September. It's incredibly important that we monitor and recognise the harm that is being caused, so that we can learn from that where possible. There are teams within all organisations that are looking at patient safety incidents. We implore our staff, both from a system perspective, but also provider perspective, to report examples of where they think harm may have been caused, because of course it's sometimes very difficult at the outset to identify where harm might be caused because of a delay, given that when the ambulance arrives, albeit late, the patient may still be reasonably well. Having said that, if they are showing signs of a stroke, that delay may then transpire into what might be harm later on in their care pathway. So it's important not only for us to capture the harm perhaps at the front end of that pathway, but also ensuring that we identify where patients may have had an unfavourable result because of that delay towards the end of their care. So did they leave hospital with a disability as a result of a stroke because of a delay that they experienced at the front end, at the point of contact when they called the emergency services? So we have a good process by which we can collate that data, we can share that data, and where necessarily learn from it as a system as well as a locality.
Thank you. So is that because suspected sepsis would be a category 2 patient, stroke could be a category 2 a patient. You know, I looked at government guidelines around, if you think you've got this, time is of the essence in these particular conditions, and lots of other things too. So I just want, so you collate that data. Is that something that we can see? Because I really would like to know what harm this is causing residents in my ward, people across the city. I obviously have a personal experience, but I'm not just talking about what I've been through, because I spoke about it on the BBC this morning, and I've had email after email from people who don't know me from Adam saying this happened to me, and I'm convinced that X happened because an ambulance didn't get to me in time. And I think it's great to have learning, but if we don't, you know, I feel reassured about the 111 stuff that we've discussed, because there is a plan, there's a concrete thing that's going to happen in September or October. And I mean, I'm not normally on this committee, but this committee can look at improvements that might happen because of that and say, okay, that's a solution, that's worked. The one solution that kind of jumped out to me was this: create the pathway for 999 to admit directly to MAU. But that seemed, you know, Q3, Q4 at the very earliest seems, it doesn't seem urgent enough to me, I suppose, is what I would say to that, because that seems a very logical, purely, you know, from a layman's perspective, having been involved in this for a few months because of personal experience, that seems like a really good, solid improvement that really could make a difference. So something around prioritising that in some way would be something that I would be really glad to see. And also, how do we get to see the data that you talked about that you collate around harm? Thank you, Chair.
Thank you. So I think we can bring that data back to this to the next meeting. That's wholly appropriate. It will of course be anonymised or redacted where necessary. The actions within that log, there was an acute medicine pathway review on Monday where we invited colleagues from other trusts that perhaps are less challenged in this area to visit UHP and monitor the pathway from start to finish to understand whether or not there was support they could provide. I think it's fair to say, and Joe may wish to comment, but we still have a single point of entry to University Hospital Plymouth. The majority of our patients go through the ED, and we recognise that there are some fairly quick changes that we can make to ensure that where possible, that the patients that may be sort of appropriate for the alternatives within the hospital are taken directly there rather than waiting within the ambulance queue at the front door. So I think there are some logistical changes that we can make. Emissions avoidance that we'll come on to is also another key, identifying those pathways that we know have demonstrable benefit, not only within our own system, but on a national scale, that we implement those. And that the same day emergency care, as you quite rightly picked out, is one of those key enablers. And I'm pleased to say that there is further investment in University Hospitals Plymouth to expand the offer of the same day emergency care service so that we can route more patients through that, therefore avoiding the ED altogether. So I would like to commend SWAS at this point, because I think they have one of the lowest conveyance rates from a national perspective. There is, I suppose, patients that are being treated at home, appropriately so, and are not recontacting our services. And that is testament to the ambulance services capacity and capability. But we recognise that perhaps at the front door, we need to make some of those logistical changes that I mentioned, but also ensure that where possible, we divert the emergency department altogether. And if that's through appropriate non-conveyance to hospital, appropriate use of alternative pathways, and better routing of patients through the hospital if they do need to be in hospital, all of those three things are incredibly important to ensuring that we eradicate the ambulance handover delays. I think lastly, what I wanted to add is that we have supported the risk share proposal that has been put to the region, in fact, that will support the funding of additional resources whilst we set up those improvement actions and deliver upon those. So SWAS approached the wider system to ensure that actually, whilst they are still finding it challenging to achieve their Category 2 and Category 1 performance, that additional capacity from a resource perspective would be needed. And all 7 systems, I believe, all 7 counties, in fact, have signed up to that risk share proposal so that we can put additional resources on whilst we deliver on the improvements that we've promised.
Thank you. Lee.
Okay, I'd just like to thank David and his staff for the wonderful work that you do. And I in no way blame you for failings in the system. I think the service that you provide is absolutely second to none. I wouldn't expect any of the doctors here to know about a response time for this. You said 7 minutes. Yeah? To try and prevent that, you take these. So when we come back, I think we need to look at what's called patient experience. I need to rely on you to respond within 7 minutes to save my life. That is from Derriford roundabout to Manadon roundabout. Unfortunately, the other day it didn't happen. But that was my fault, not yours. I say this on the basis because it's about being real, I think. Not talking in academic terms, not trying to manipulate figure statistics, but actually being real about what we're talking about. The pathway, I think the pathway is the crucial way. 1 hour, 111, fail. When they eventually got back to us, can you go to the Cumberland Centre? 2 hours in the Cumberland Centre, nurse-led. What were all the staff saying? We need a doctor. We've done the triage. You need to go to hospital. We need to call an ambulance. I said, well, don't go wasting the ambulance time. I will get them myself. 10 hours in ED following triage. At hour 10, I was mysteriously discharged. We'd formed a group of 13 people in the corner, and apparently my name was called. However, the interesting bit was my partner was there, as well as the 13 people who looked at the reception desk and said, well, he's been here all the time. Panic. So I go in to see the doctor. Luckily, I had certain medication to try and hold things back at bay. She realised I was going into anaphylaxis, put the needle in my arm, and then I'm in resus for 6 hours. Speaking to the consultants, because they asked, what I did for a job at hour 11. I said to them, I work for Plymouth City Council. What do you do? I said, I'm a bin man. She laughed. She said, what do you really do? I said, I'm a counsellor. I said, no, tell me what's gone wrong. And this was a consultant. They don't understand mast cell disease. It's a new thing. And they appreciate it as a lot of GPs don't understand it. In fact, I went to a doctor's surgery once and the doctor said, well, that's a new one on me. All right, so she said, we're in the period of learning on it. But she said, the problem that we got is that you've been triaged once in the Cumberland Centre, because there's no GP provided by the CCG that they could send people to and discharge that way, you have to go to Derriford to be re-triaged again. So you're going through the same system twice. They said if we had a triage for general people that just need to see a GP in Derriford, that would make that accessible to that pathway. And the second pathway is if somebody like yourself who needs acute care straight away is sent the other way. So to actually to reduce the problems with regard to the pathway. So what I want to say is that no matter how people slate the ambulance service, I and many others see it's not the ambulance service at fault. However, until they clear these pathways up, I need care in 7 minutes. Am I going to get it?
I'll just respond there very briefly, because we do have a really good working relationship with Derriford ED, and everybody within there is working really hard at the moment. They have introduced, we've got a system there whereby we've got an agreed Cat 1 process where we keep a trolley within a department, and at any point, if a Category 1 call comes in anywhere in the locality, and the nearest available ambulance is going to be from Derriford by the time you count and handing over. So they add 5 minutes on. And if the nearest ambulance is at Derriford, the crew just push the patient into the emergency department, take an empty trolley and leave and respond to that Cat 1. And the other thing they do to try and improve the patient experience, if we arrive in an ambulance and we've got extended waits, there'll be an experienced paramedic called a Halo there, along with a clinician from Derriford Hospital, who will review the patient and start the patient journey. Now, if that means they review the patient, they take bloods, commence any diagnostics that they believe are appropriate, they will start that journey, even if they don't have the space, and the patient still has to wait in the back of the ambulance. So they are doing everything they can to try and improve things at the moment, given the pressures from a patient experience.
Thank you very
Just
much
a
indeed.
supplementary question, please.
No, for the moment, no, I'm holding it. For the moment, please. Would an urgent treatment centre based somewhere up in Derriford, that sort of top north of the city, be of benefit to the whole system to take some of those pressures off?
Yeah, thank you. We had 2 national visits in December and January, predominantly looking at some of our structural deficits in terms of space and the volume of people that turn up and walk in. And just going back to Tony's point, we are seeing a huge number of people walk in because of the waits for ambulances as well as arriving in ambulances. And one of the key recommendations from the national visit was that we had a UTC on site within 2 weeks of the visit. Unfortunately, there is no space within the hospital, and we've not been able to find a source of funding. But we have been able to buy the Northwest Quadrant in recent months, which is the space on the Derriford site up by Costa, for those of you that visit, and that does come with existing planning permission. So we have a business case ready. We're currently seeking options to get capital and revenue funding to try and put a UTC on site.
So Joe, who would be funding this project, and so that we could write to them and say, and demand it for our citizens?
So we have, so our routes of communication are through NHS England currently.
Okay, folks, I'm asking a recommendation agreement there, folks. Yeah, thank you. Ross, I will leave it to you to sort that out. Now, Lee, my problem is now I have got 4 more people. Technically, this session this afternoon is supposed to be finishing at 4, and we've still got admission avoidance, same-day emergency care and emergency department, hospital discharges to do. So if it's something that can wait and it's not critical to this, I'd rather move on, please. Okay, thank you. Patrick, you're next.
Thank you very much indeed, Chair. And I'll echo Councillor Finn's initial comments. The ambulance service are here not through their own fault, but through system pressures that we all recognise have been around for a very long time. So, hopefully as a system we can overcome it collectively. Certainly the paper that's been presented on handover improvements is to be welcomed, and I am surprised and had personal experience why people in the care home sector, when they topple over, the ambulance service are required to lift them up from the floor, and that the wider healthcare system with health professionals in care homes can't have the means and the ability to lift a resident from a care home having tripped over. So, certainly think that is one for the City Council to look at from the care sector, because that can't be acceptable, where you've got other health professionals who should be, through manual handling and various equipments, capable of lifting a frail elderly person in a care home establishment. So that in itself would ease some of the stresses and strains at Derriford. So, certainly, the health service have done extremely well being imaginative to deal with COVID, and I hope from this ongoing pressure at Derriford for the citizens of Plymouth, we can be as imaginative as possible to try and resolve the stacking of ambulances at Derriford, because it's something that it can't be sustained in the longer term. We've heard from fellow councillors the impact that it has on other citizens who try to access emergency care. And it can't be right that the ambulance service are really the ones that have probably taken the wrath of the public because they're not able to attend because they're waiting to discharge. So my couple of points, hopefully Anna will come back and have part of the action plan, what we're going to do to try and train up the healthcare community to deal with frail residents in residential establishments. But for Derriford and Joe specifically, clearly you're talking about a proposal about building a facility. Well, that's going to take time. What could we do though, like we set up Nightingale facilities to deal with COVID, something similar of a temporary nature to have a more immediate impact on handing over occupants of ambulances to the UHP in a timely manner. And that's the challenge for today, Chair.
Do you want to come in first, Anna, on that one?
Yeah, thanks, Chair, and thank you, Councillor Nicholson. So I think we've heard from colleagues clearly a lot of improvement work needs to be undertaken in this space, and I think we'd all acknowledge that we're not in the place that we would want to be at all. In relation specifically to care homes, I think the first thing I would say is that we have seen a reduction in attendances from care homes over the last couple of years. So it has been an area of ongoing work, but we acknowledge that there's more to do. So in relation to the specific ask of reduction in ambulance handovers beyond 30 minutes to the 1st of September, we're working really closely with Live Well South West and the Trust in relation to those care homes where we're seeing higher levels of attendances or admits that are clearly having an impact on Davey and his crews. And I think there is more to do there in terms of that wraparound support for those care homes. As you know, Councillor Nicholson, staffing in care homes, supporting care homes is really challenged also. But we do think that there's more that we can do. So there's some investment from Devon, from NHS Devon in relation to enhanced health and care home services. And we're just looking at how we can really put in some targeted support through pharmacy support, through nursing support, through therapy support to those care homes to try and ensure that if those residents don't need to go to hospital, because actually sometimes residents in care homes do.
Sorry to interject. So on the issue of somebody falling over, my personal experience is that they call the ambulance service. So why can't a nurse or a suitably qualified individual, so I'll take Councillor Deacon for instance, if somebody toppled over, why hasn't he got the capability and the equipment to lift that person up? Why do you need a paramedic to come and do it?
So I think that's the point, Councillor Nicholson, is actually we need some clinical support in around the care homes as well in order to assist with that. So one of the key areas is absolutely looking at those care homes and looking at what we can put in relation to equipment, relation to clinical staff, so that the care homes don't need to phone the ambulance if that happens. So absolutely key area of focus. Okay,
and Joe, any thoughts as to something to sort of bridge that gap between a brand new building and a practical solution?
Yeah, so you're absolutely right about the UTC. We need it, but we're not going to get it in time when we need it, but we do need it as a sort of medium-term solution. I think Davey and I have been jointly involved in discussions around what they call pre-ED cohorting, and it's where the ambulances are able to offload before entry into an emergency department. I think what I would say is that it's happened in some areas of the country and it comes with further significant risk. So we're back to the risk conversation. Yeah. So do you put sick people in a vehicle in the car park and they're sick and they can't get in and they haven't been triaged, and then the crews go back for the next patient, and what's the risk to that? So we've explored it, we've talked to CQC about it. At this current point in time, I think it's the collective decision that it isn't the right thing to do. And I think the national position on it is that it's not the right thing to do from current experience. We talked about it last week again. Could we put something on the northwest quadrant? How would you practically assess people? And at this point in time, we can't find a safe solution for that. Every day, we're just trying to have a think about what else we can do. But I will hopefully, when I do my bit, talk through what we are doing. And do you know what? Anybody's got any ideas that we haven't thought about, we're totally up for it, because it's really challenging. So, but on that particular one, it's a no.
Thank you, Joe. George.
Thanks, Chair. I had a couple of questions, I'm afraid. One following on from Councillor Lang's earlier questions. The graph of the number of ambulance incidents conveyed to ED is, on the face of it, encouraging in that this time last year there were more than twice as many being conveyed there as there are this time. Does that mean, though, that there are half as many attendances at ED as there were this time last year, or does it mean that they're getting there without going by ambulance? I suspect it's the latter, and I think an indication of that would help. And there is a worse scenario, because the implication there must be that some of them aren't getting there at all, and we I think need to know something about that, because that's a really serious aspect of all of this. So if there was some way of representing that to a future meeting, I think it'd be very helpful. My other quick question, I think, is why is it so much more difficult to get to Derriford from West Plymouth than it is from Medium or East Plymouth, from Middle or East Plymouth? Why are the postcodes on the west side of Plymouth so much worse? Well, I say so much worse. It's only 10 minutes, but that might be significant. Why is that?
Okay, I think, Joe, if you can take the one bit, and then Davey, I don't know whether you can answer anything about the times that it takes. So if we could do that between you.
Yeah, sure. You're absolutely right, George. So we've done a lot of work with SWOS, and as Davey says, we've been working really closely together. And Anne Hicks, who's one of our really experienced ED consultants, we've put Anne into sort of interface role. So she works with SWOS, primary care. We've got a GP lead for the urgent treatment centre. She's just visited 75% of GP practices to talk about all the pathways they could use and do some sort of education around that. But actually, and some of that work means that there is a reduction in ambulance arrivals, and some of the work with 111 and clinical validation means that before those ambulances are dispatched, not for the really urgent ones, there's a clinical conversation about could we do anything else. So we know that we've done some improvement work that's reduced ambulance arrivals, but we also know that the other part of that is that they're waiting so long to offload at Derriford that people are finding an alternative route. So a few weeks ago, ED said to me that, Joe, the acuity in our walk-in section, because for those of you that used it, there's two entrances. There's the ambulance entrance of the walk-in. We've got people walking in that are extremely sick. So actually we've done some analysis of that, and what that shows us is that we've seen a consecutive increase in the sickness of patients arriving in that queue. So we've still got people who could go elsewhere. We've got people who need to come, but we've got people who would normally have probably come via an ambulance walking into the department. So we've had to shift our staffing model in ED, because actually we need to look after sicker patients in the other side. And normally you would expect people to be admitted from what we call majors, which is where all the ambulances come. And now we're seeing an increasing number of people needing a bed from the walk-in side of ED, where they've walked in and had an equally long way on a chair for a bed in the hospital. So we've done that analysis. It does show us an increase in acuity. And you all know that we're a major trauma centre, and actually we, some of the NHS England work that they do around activity shows that we're in the top 3 in our area in the sort of south for the acuity or level of sickness of people arriving to our major trauma centre. So we're seeing an overall increase in how sick people are.
And the conundrum about the mileage.
And for the second part, I'm really sorry, Councillor, I can't answer that. I would need to pass it back to the business intelligence team to see if there's a breakdown in time of day or something. But at the moment, I can't answer that.
Thank you. I've got Philip. Then I've got David, Zoe, Natalie, and Mark. And then I'm putting a definite line under that. Then no more after that, folks.
Chair, sorry if I just may, to speed things up as you requested, my question can wait till next meeting.
That's okay. Philip?
Chair, I'll keep this brief, but I can wait for the answer till the next meeting, just gives the colleagues on the other side a chance to give me a fuller answer. Running down the ambulatory handover through 999, looking at going into handing over patients to MAU, AAU, and the other one I can't call off the top of my head. Is it possible that 111 can also have an extension of this service, which would cut down on a huge amount of patients who really need to be seen by a GP or a suitably qualified consultant, which would ease up the burden on your junior doctors within the ED? I don't want an answer now, but if you can bring me that answer back in September, I'd appreciate that. Thank you. Thank you, Chair.
Thank you. Okay, Zoe.
Oh, well, I was going to withdraw my statement, but I'm going to go with it. And I hope this doesn't seem like I'm being argumentative in any way to you, Councillor Nicholson. Last week, I had the privilege of visiting some care homes where there was a lady who had been taken to hospital because she laid on the floor for 6 hours waiting for an ambulance. There is one nurse here in this care home who's already exceeding hours that I would accept and you would accept. So she's already working far more. They have agency staff that want no more than 6 people in their care, and there are 30 people in this home. So I think maybe what we could do as members is perhaps look at what's actually going on in there rather than suggesting that a nurse should pick someone up off the floor, because if there's not enough people to do that, there's not enough time, there's not enough people to spread that out, in my opinion. Thank you.
Thank you, and that's something that Anna and Craig will be taking up with workforce stuff at a further stage. So yeah, I'm happy to leave that with that. Natalie.
Thank you, Chair. Mine was really, I agree with everyone saying the ambulance service are doing a fantastic job, and in my belief it is not the fault of the ambulance service that there are the delays that are happening. I can totally see that obviously it's the pathways that are clogged up. So my question is, how are we moving this forward? Is it about getting people out of who have been in the wards and perhaps not being discharged, being clogging up the system, so that actually some of the people that do need to have a bed cannot have a bed and therefore waiting. My worry is, with sort of finances the way they are, freezing of budgets, as we know, is any of that having an impact, or is it about what Councillor Riley has been saying already? There are not enough staff in the care homes to be, for us to be able to discharge, and then it's coming back to the ambulance service as if that it's their fault. Which, as I say, I applaud what they do, and I appreciate everybody in the ambulance service and in ED and across the UHP are doing as much as they possibly can.
Excuse me a minute. Can I ask you two gentlemen to be quiet, please, because you're muttering well and we can hear you over Natalie trying to say what.
Thank you. So what is, with what is being done, is that moving forward at all?
So I think what you'll get from today is that there are, that there isn't one area that will resolve what is a set of really complicated challenges. And some of this predates COVID, and what I think we'll present to you today is that we're working collectively to address that. So clearly, if there was capacity across the system to support more discharges, that would help. Clearly, you'll hear from Joe the work that a hospital's doing in terms of pathway redesign, how we could manage some of that demand. Clearly, you'll also hear from Livewell colleagues later on the work to do to prevent admissions in the first place. So I think it's multifactorial, and I'm hoping that through the rest of the slide deck that we've got, you'll be able to see, Councillor, that there are incremental pieces. If I think we would all agree, if there was a magical silver bullet of the one thing that we could all do that would, ensure that service provision is in the place that we would all want to feel that it would be for our residents in Plymouth, then we would absolutely be doing it. I think, it is with the workforce challenges across the healthcare system, across the social care system, actually it's about those incremental areas of improvement, and I'm hoping that we'll be able to describe that through the later slides, and you'll be able to see all of those bits coming together. But clearly, discharges from hospital is a key area that we work on a daily basis and will continue to work on, and you'll hear some of the initiatives that we're developing to try and improve that position. But also what you'll see is some real green shoots of improvement from certainly when I was last here meeting with you to do an introduction to the health and care landscape. The Plymouth discharge position has improved significantly in that respect.
Mark.
Thank you very much, Chair. Excuse me. It's been reported in the news that the Royal Devon and Exeter Hospital have lowered ambulance waiting times through a rapid assessment and triage system. Why can't Derriford operate a similar system to the Royal Devon and Exeter? And if there are challenges, then perhaps we can have a trial to see if ambulance waiting times improve.
Thank you. So I think I would just go back to what Anna said about the many things that make a difference to us. So if you think about our population in Plymouth, we've got 25% of our population in the lower deciles, compared to I think 2.8% in our D&E or our DU. We've got varying differences in the fact that we're a major trauma centre and we take tertiary patients. So I think when we talk through the slides, I would just like to check and share with you all the complexities of what we're dealing with. We do have a slightly different model, and we are going to try a RAT model in our ambulatory area. And just to come back to Councillor Lang's point about the MAU, we are going to try it in July, towards the end of July. What I would say to you is that we have, before COVID, and I'll talk about this in my slides, we knew we were about 80 medical beds short in the hospital. As we speak, we've opened 50 escalation beds on top of the normal beds. We're doing a full capacity protocol, so we've got 40 people in corridors, in wards, where there's no bed space. We've got another 30 patients in ED awaiting a bed on a ward that's full. And we've got patients in the car park waiting to come in from the ambulance and patient at home waiting for an ambulance. So even if we do a model like that, it still depends on the capacity to meet the demand. And I think Dave is absolutely right. There's not a massive increase in demand, but there is a change in acuity, occupancy, and I will show you the slide, but this time last year, we had 35 people that were delayed in hospital, and today we've got 105. So we've got a length of delay caused by that. We've got a length of delay caused by people with COVID. We've got a length of delay caused by the fact that people are sicker, and we've got a length of delay because we're really only operating on very sick patients. So every day we are bringing in about 10 to 12 patients for elective inpatient surgery. Everything else is emergency. So when I'm looking at who gets a bed, I'm looking at patients with brain tumours, with cancer, who've been waiting a very long time for surgery and in the back of an ambulance. So the decisions that we make dynamically every day are extremely challenging. So I think we're doing lots of improvement work. Actually, we are seeing green shoots, Anna's absolutely right, but it is from start to end of the pathway that we're all challenged. So we absolutely are going to try that, and I hope it'll make some difference. And we've done quite a lot of different training with our staff, A, because the needs of the population's changed, but B, because actually we need to retain people to work in what is a really challenging area to work. We've had some challenges with our UTC in terms of staffing, and our new head of nursing for urgent care has developed what we're calling a practitioner model, which means people can work in Cumberland, in Tavistock, in Derriford, and we can rotate people, which will give people a bit of a chance. I'll skip over my slides when I get there, Anna, but I think because we're cross-cutting, I think it's important just to share the sort of global picture.
Thank you very much, Jo. I would like to take this forward if I can, because I think possibly it could be a way forward, the RD and E model, but I do take your your comments about the elderly population and the trauma, but it's something that we really need to grasp and actually do better on.
Yeah, we're going to have a go at it, Councillor Deacon. So it's in the plan. So as well as trying the MAU, we are going to try the RAP model, see if it makes a difference.
Excellent, thank you very much.
And we look forward to hearing more about it, because obviously now we're hitting that summer period. you know, the COVID rising anyway. And then, of course, we've got all those lovely holidaymakers coming down who have mishaps and whatever, let alone our own population. So I can appreciate we're going into a more difficult time as well. But Joe, an update, you know, for September meeting if possible, but if not, the meeting after that, that would be really fabulous to find out how things are going. And certainly, please, Davy, send our best wishes to all the ambulance crews, because we know the professionalism behind them there is absolutely first rate, and we all value the work they do, even if they have to sit in the tin can in Derriford car park. I hope Joe and Co look after them and give them drinks, but yeah. So thank you very much indeed for coming along. Now we're going to move on now to admission avoidance, which has obviously got a very, this is very sort of poignant with all of this, because if we can avoid having somebody turn up at the hospital or whatever, it's got to be worthwhile. So there'll be a quick jiggle around of seats. And I'm going to temporarily hand over to you, because I wanted to leave. All right. Okay. So there's the magic list.
Thank you, everyone. I just want to say that Philip needs to leave the meeting in 25 minutes' time. Over to Anna.
Thank you, Councillor Deacon. So we're just now moving on to the admission avoidance section of this afternoon's agenda. So delighted to welcome Ian Lightley and Sarah Pearce to join us at the table. So it's very much the area of focus around the work that we're collectively doing to support people in the community to manage their care needs in the most appropriate setting. So we've got a few slides around the work, current performance, and then also some of the ambition for the future. So I think I'm going to hand over to Ian, or am I handing over to Joe? No, I'm handing over to Joe.
The first slide's probably me, and I think I've already shared some of this, but I did want to come back to your experience, if that's all right, because I think you were passed from pillar to post during your recent experience, Councillor. So from a minor injury and urgent treatment perspective, we've got Kingsbridge, Tavistock and the Cumberland Urgent Treatment Centre. And as you can see from these graphs, we are seeing an increasing number of people attending. In fact, we've seen a real rise in the last few months, and certainly in June. We have had a challenge with staffing the Cumberland Urgent Treatment Centre, so we reduced the operating hours by a couple of hours, but what we've seen is the same number of people that we would have expected to go through in a smaller number of hours. As I said, we've got a GP lead, Ruth Bath, who is fantastic, and Ruth visited 75% of the practices in Plymouth, and we're also reaching out to East Cornwall just to talk through what people can use and what GPs can use in terms of what's the best thing to use the UTC for, how can they access the same day urgent care pathways in the hospital, how can they access the acute GP service or some of our specialist pathways. And that's been an education roadshow just to make sure people know what they can do, because to be honest, sometimes when you're in the middle of it, you can't see the wood for the trees, and that's been really well received. And I do have a slide deck on that should councillors want to see that in terms of the feedback from that visit. As I said, we've trained a huge amount of our staff now in what we're calling a practitioner model, which means those staff are trained to do minor illness and minor injury and can do that whether they're in Derriford, Cumberland or Tavistock. There's a directory of services, so when you ring 111 and you give them your details, that directory of services should decide which service you go to. So I think if we're finding that people are being sent to Cumberland and actually Cumberland can't treat it, it needs to come to Derriford, we just need some feedback on that, because clearly there's a hole in the directory of services, because technically you shouldn't have gone there and then been re-diverted. Some people turn up and they've got a fracture or an issue that the team can't deal with, but it is nurse-led. Most minor injuries, UTCs are nurse-led with GP support, which we've put in, and 90% of the time that works well, but sometimes people go with things that we can't treat. so they get transferred to Derriford. It is under Derriford's umbrella, it is under the oversight. We've got two clinicians from Derriford attached to that now, not full time, but obviously overseeing the development of staff and clinical pathways. So more to do, but I think real improvements in how we run that this year. Sarah.
Hopefully that's on. Good afternoon, everybody. I'm Ian Lightley, the Chief Operating Officer at Live Well South West as of last week. So just before I start, just listening to everything today and just a bit of a personal reflection, having gone through a professional route of social work and having a background in mental health, which I'll come on to in a minute, I remember learning about what life would be like in 20 years' time when I was studying, and I think hearing everything that we've heard today is what I was expecting we'd be facing. So I think we've mentioned workforce, we've mentioned pressures. It's really tough. It's really tough out there. So I'm not going to labour on that, but I'll touch on it a little bit when I go through these slides. So what you're looking at here is a cut of data that's relevant for one particular service that Live Well provides, which is our mental health crisis response service known as Mental Health First Response. That service came out of some work done years ago through the coalition, which was around parity of esteem. So it reflected the fact that if I was in a physical health crisis, I could expect a very quick response. But if I was in a mental health crisis, it was much more difficult for people to get that help. Very often people would have to go through hurdles. They'd have to be screened by different professionals. And the definition of crisis itself often got in the way. So this service was a response to that. In Live Well, we stood it up in 2020 in the midst of the pandemic, and it was in response to the pandemic because it was one of the measures that was taken to try to prevent people going to ED in a mental health crisis, when of course we were trying to prevent any unnecessary footfall in the hospital at the time. So it's been around for about 2.5 years, and that's what it does. So it's open access to anybody, doesn't need referral, people can ring up now. So it's important to note that what you're looking at is the whole of the activity that that service deals with, and it's not specifically people that would otherwise have gone to ED, but one of the elements that we've included in that is the fact that when we do get to speak to people from 111, for example, and we are able to offer them our support in a very high rate, I think 99% of the occasion, we are able to provide an alternative option. And there is no reason why, unless somebody has an urgent physical issue related to their mental health, that they should ever need to seek mental health crisis support from ED. So we've done a lot to promote the service, to make sure people are aware of it. And we've done work with colleagues in UHP within ED to try and divert people away from it. And what you can start to see there in the graph, essentially, is that the number of people using it and calling that service has started to grow. Now, there is a slight corresponding drop there in terms of how many calls we answer. So that's as much to do with the clustering of those calls as anything else, because we can't ask people to call us in a sequential order. So there are pile-up times during the day, but it's still a favourable response time when compared to similar first response teams nationally. So it's getting worse, but you can see really the correlation there between more phone calls, more likelihood of some of those dropping off. So there are other schemes which we'll touch on briefly at the end in terms of the action point, which also link with that service around alternatives to ED. But at this point, I'll hold over to my colleague Sarah and let her introduce herself and describe some of the equivalent activity we do in our community crisis response team.
Thanks, Ian. Afternoon, everybody. I'm Sarah Pearce, Head of Service for Adults, Frailty and Specialist Services in Live Well. So just really want to give you a bit of an overview of our Community Crisis Response Team. So Community Crisis Response Team is a multi-professional team made up of nurses, therapists, social workers, paramedics, support workers, a really wide range of professionals, and their focus is on alternatives to admission to hospital. So the team work 8 till 8, 7 days a week. They work in people's homes and in care homes across the city. Since November of last year, we've had 8 till 8 in place 7 days a week. Prior to that, we only worked up until 5 at the weekends and bank holidays, so we've seen an increase in our activity. So the first graph just gives you a flavour of the total number of referrals, and you'll see that those go up and down. And the second graph, I guess, gives you a flavour of where we're caring for people on the community crisis response team caseload. So on the caseload, people will have input from the team at the point of crisis. They will be seen by a professional and from the telephone triage. So when people call in, they speak to a professional. They'll understand what they can do on the day. They may be able to manage and signpost that person. They may be able to do a digital consultation with that person. If they need to go and see them in their care setting, they go and do that. And that'll be the professional who is most likely able to meet the needs of that person. So they'll do the initial crisis response and they'll work with that person for a period of up to 6 weeks, providing intermediate care services with the aim of trying to help that person get back to near as independence as they were prior to their crisis. So you'll notice that we've had an increase in caseload, and that correlates really with our increase in opening hours. So you'll see that since the end of the year, we've had an increase in caseloads, and also that we're managing more people in care homes. And I guess one of the important things to note, just talking about earlier, we work really closely with our primary care colleagues and our SWAST colleagues. So SWAST have direct access to the community crisis response team for not just crisis calls, but anything that needs care management in the community. So if SWAST go to somebody in their home or in a care home and they think, I could leave this person here with community services, even if it's not a crisis, they can ring it through to our CCRT and they will case manage that person so that SWAST can be released to get onto their next call, and they will see that person within 2 hours. So this slide just gives you a flavour of our 2-hour response time. So prior to November, there was no national requirement, I guess, to be looking at a 2-hour crisis response time. And there's a standard called Urgent Crisis Response Standard. So from April of 22, that's been in place, and there's a requirement for us to achieve a 2-hour standard to anything that is an urgent crisis response. There's a new standard just coming in now for a 48-hour response. So we're working that up in Plymouth. So our crisis response team deal with both 2-hour and 48-hour, and we're doing a bit of work to make sure that we're illustrating those really accurately. So you'll see that prior to us starting our 8 till 8, 7 days, we have more instances where we didn't achieve our 2-hour standard. But in general, we're doing pretty well. And obviously, we just keep reviewing that and keep working towards achieving that 2-hour standard. And I think, am I handing back to you, Joe, for the plan? We've got a bit of all of us on the plan, haven't we?
You know, my eyesight's really bad, so I'll go for the paper copy. So I think, so one of the things that I will show a slide on later on is the opportunities for same-day emergency care. So that's when people turn up to the emergency department and we try to treat them and discharge them on the same day, having had investigations. So what I would say is same-day emergency care is not just a place, it's a pathway. So if you need a specialist pathway, then you should be able to go direct to the ward. And bearing in mind there are obviously capacity issues, but you should be able to go direct to the ward and be seen. And in COVID, all of that stopped because of COVID, so we've resurrected it. And we have our acute assessment unit where we also do that. And in May, we treated 2,400 patients through a same-day emergency care pathway. That is about 40% of the patients that we could treat in that way of emergency attendances. Actually, the Devon average is 37%. And the national average is around 38%. So we're doing quite well, but we already know there is so much more that we could do in terms of that pathway. So I think we're really ambitious to get ourselves up to about 50% and try and treat as much as we possibly can through those routes. So that's one of our key pieces of work that we're working on at the moment. And it links to the work that Jemima was just talking about around the MAU model. So historically, we would bring people through MAU from GPs. Again, through COVID, all of those pathways stopped. It isn't a huge pathway for us just because of capacity. So that's where we do differ with RDU in terms of the space to do it. But we're going to take a bay out of one of our medical assessment wards to put chairs in to trial that and to see if we can turn that over and create some more space while we get to a better solution. We've updated the directory of services, and we are working on mental health pathways. And as I've said, just in terms of the alternatives, we now have a sort of integrated meeting with SWAST, primary care, urgent care and ED around did those patients need to come. And we're in the process of talking about call before convey, which is where if you have a patient in a care home and they can be managed at home, Anna and I are just working through what that might look like and the access to the acute clinicians to do that. We have an acute GP service. They run the acute assessment area and all of the same day emergency care. But what they also do from ED is where there's patients that would otherwise be admitted out of hours and in the evenings, where they can, they send those patients home and the acute GP service manage those remotely, and they only really bring a few back in. The rest, they find alternative pathways and treatment options, and because they're GPs, they do have a better risk threshold for what can and can't be managed in and out of hospital. So we've got lots of work to do, but I think we've seen real improvements. We've seen an improvement from 29% of our patients going through same-day emergency care to 40%, and that puts us in the top second quartile nationally, and we want to get to the top so we can do as much as we possibly can. I don't know what's on the next slide.
I think we've basically moved from the avoidance onto same day things. So yeah, if you're happy to, if anybody's got any particular questions for Sarah before we move on any further. Patrick?
Thank you, Chair. It's just on this little section, and I think we should offer our congratulations to all the presenters on this paper and all the initiatives, so well done. The point I wanted to raise, Chair, was clearly GPs are probably part of the problem with people turning up at an emergency department, and clearly, you know, targeting them is important. My point really is to NHS Devon, who obviously the organisation that contract GPs. One would hope that NHS Devon are also putting pressure on GPs to ensure that they take responsibility not to just flippantly pass people off to the emergency department, but actually to try and signpost people to other facilities, because you know there are examples in the community when the GP will say, well, you'll have to go to the emergency department, and that's not acceptable. So I hope NHS Devon are part of this initiative, monitoring the performance of GPs. And I'm not sure, Joe, do you ask those attending the emergency department why they've turned up in terms of creating data to see how many are turning up because GPs are telling them to go to ED?
Can I just say that's probably something Tony can help with that answer, because that was one of those things that you looked at, wasn't it, Tony?
Yes, it was. So the ED report we produced this time last year and was eventually published in the December was asking those sort of questions, and I think it's a mixed bag really. There are evidence, or there is evidence of people coming through from GPs to ED, but the report is 12 months old now. So as we discussed earlier, I think before you came in, Councillor Nicholson, was to repeat that survey. But it'll be useful for us to do that across the whole of Devon again, so that you've got some comparisons there.
Thank you, Tony. Thank you, Chair.
And I think that's also something else, Joe, presumably you will pick up as well, as that understanding is, it shouldn't just be Healthwatch that's understanding why people are turning up there, isn't it? It's Healthwatch just sort of getting some of the data, but you should be picking that up yourselves.
Yeah, we've just introduced a new electronic record system in ED called Nerve Centre. We've been waiting for it a long time, and I'm hoping it's going to give us more accurate data. One of the things I would say, though, that I'm really struck by most recently is there is such a lot of press around how hard it is to get a GP appointment and how hard it is to get an ambulance. I think it overshadows the Choose Well campaign. So, you know, we're trying to tell people to choose well, but on the other hand, we're saying no one can get an appointment. So I think people choose ED, you know, so I think people, you know, don't always try because they think they're not going to get through. So I do think it's really important going forward that we think about our communications campaigns as a system, because I think we offset the good with the difficult news, and it's really difficult to manage. But yeah, it's a good question, and we do get GP referrals, so they'll refer in if they want us to see people, but we get people who will tell us they've called 111 or GP, and we have no way of really knowing whether that's anecdote or fact at the moment.
Thank you. Just so the committee, I mean, most of the committee know this already, but I was pleased to be able to write a letter of support for the West End Health Hub that's planned. And there's so much work has been undertaken to get that going and moving. And I know Councillor Nicholson was part of that, and I know Councillor Tuffin, I think, was probably one of the original people when that was mentioned. So if the hub is not delivered, what would the impact be on the residents of the city centre? I mean, obviously, we know that the city centre health services, the GP practices want to move into the new hub. So what I'm going to say catastrophe can you see happening if it's not delivered?
Yeah, I'm happy to say that. Well, I've been equally involved with the project from LiveWell's perspective for a while. So I think from the simplest way of answering that is this is our chance to properly integrate primary care, community services, voluntary sector, third sector partners around a project and create something that we haven't had before. So I think it's far more than the building. I think the building is almost a focal point for some real transformation work that we've been needing to do for a while. So yeah, I think it would be quite significantly devastating. And having been part of it, there is a real appetite to create something that is far greater than the sum of the parts in the building. So a truly, seamless offer for people, which doesn't involve some of the challenges I've heard earlier around pathways and people being passed around. So I think it would be a real shame.
So I really, really want to make sure that we're all backing this. I know you were all asked if you had any concerns to let us know, but can we make sure that we record our support for the West End Hub?
Chair,
Yeah. Anybody going to dissent?
Chair, on a point of order, is there some doubt about it?
I think we just need to be making sure that all the powers that be know how supportive we are of it, and that we would be very concerned if there was any change of view. So I think we're
talking
just
in riddles. My understanding is council policy is to deliver
Yes.
it. And clearly there's a funding package, but the council are involved in it. So I didn't know the council were doing any other than trying to work with partners to deliver it. And if it's
I just want
otherwise,
the health
then
scrutiny.
I think that
No, I just want the health scrutiny committee to know that and to put on record that we are very supportive of it, and we are pleased to be able to recommend it.
Sorry, just deal with the point of order. Thank you, Councillor Nicholson. I think it's fair to say that the chair had to offer a letter of support without the West End Health Hub being discussed in any way at this committee recently. So it's just to really reaffirm the position of this committee in support of that project on the basis of the chair's letter, which we sent earlier this, I think it was earlier this month, and you should have all had copies.
Thank you. Lee, you're next.
Yeah, just to say, I appreciate the work everybody's doing, but I do take offence at the fact that when people say we don't need any more beds, for example, if we go back when I was a child, what have we lost? We lost 8 hospitals in Plymouth that have gone, and there was a clear separation between general care and acute care. Now, the problem is Derriford has become an acute facility. So I fully support, obviously, anything that would help alleviate that, such as the new care centre. However, I do think in the long term, and it's something that a lot of the electorate and a lot of, I have friends who are GPs that have retired and have said the same thing, that at some point in the future, Plymouth does need to look towards an acute care unit. Whereas we had, say, in Freedom Fields, we had A&E, and then we had Greenbank. We had the best A&E department in Plymouth, which we lost at the Royal Naval Hospital because nobody went to Freedom Fields. They always went to A&E because it was more efficient, and you were seen on a Saturday night and out. So we need to, I think, in the long term, when we look at projections of beds, an increase in population, especially elderly population, is going to require more care. So I think whilst I accept that we're moving in, let's say, very slowly at the moment that we need to have a vision or a vision of a 5-10 year plan to put in place that we can say, well, this is the starting point, this is the middle, and this is the end. Because if not, what I can see is that we can still be talking about this in 10 years' time and achieve nothing. So we do need to, I think another thing that comes back to with regard to the current crisis, and it's absolutely clear in the statistics that Healthwatch put over, for example, was access to GPs, 20%. People are crying out for access to GPs. I've got no problem with a mix of access, i.e. Whether it be online, phone, video, but we have to take in the mix that people do want to see GPs. And put it this way, my partner ended up with antibiotics for cancer for 3 months because no GP would see her. They put down, and I believe under the Live Well test that you're going to be introducing a traffic light system. Under your traffic light system, she would have a tummy bug and be given antibiotics. She had follicular lymphoma as a result. So the traffic light system, I don't believe, is going to work and would need revisiting to take account that a minor ailment could become a major problem for an individual, and to make sure that these individuals that trust in the health service aren't set aside. I'll leave that with you, Chair. Thank you.
Joe?
I trained at Freedom Fields, so you've just taken me on a whole trip down memory lane. I'm a nurse by trade, and it was the best years of my life, so I have very fond memories. And of all of it, from start to end. But just on the strategy and the vision, we do have a vision for a planned care centre for electives. You'll know that we've got massive backlog waiting lists. We are part of the new hospital programme nationally, the government-funded initiative. We've obviously bought the North West Quadrant prime site to build a planned care centre. We've appointed a future hospital director, which is Stuart Windsor. I'm sure he'd love to come and talk to you at some point about it, because actually he gives a fantastic presentation about what we want. It is just about the steps to that funding agreement over the next few years that would enable us to deliver that. But the first part of that is the urgent emergency care build. So it is a new ED, which is the build starts this year. The enabling works will cause more challenges for us, but actually that starts this year, and that's phase 1. So that is good news, and we do have a vision. And that vision also needs to include our collective vision around how we look after people in Plymouth and deliver care close to home and better wellbeing services, which links to your West End hub and all the work that we want to do around deprivation and population health management. So I think just to give you some assurance, it's very high on the agenda. Right.
Thank you very much. Tony, do you want to come in there?
Yeah, it's just a very quick question for Joe, and it's around urgent treatment centres, MIUs. Across the county, there's been several closures over the last couple of years due to staffing and that. And this week we saw the Totnes Centre partially reopen on reduced hours. But how has that impacted on sort of Kingsbridge, Tavistock and Plymouth itself in terms of attendance?
Not hugely. So some of the smaller units, when we have short-term closures, don't make a massive impact. When Cumberland closes, that affects Derriford significantly, and so that's the big issue. I think the smaller units we can easily absorb, unless we're right in the middle of the summer months, and then we have a challenge. But no big issue currently at the moment. And we're not intending to close hours other than when staff go off sick with COVID or their sickness at short notice, and then we have no choice.
Thank you. I've got George and Jemima.
Thanks, Chair. I think mine's quite a quick one about the mental health first response service. Very encouraging, but calls dropped have increased. Would an extra telephonist be cheaper than dropping calls? Thanks, Chair.
Yeah, so I very quickly touched on it. We done a lot of modelling around when calls come in, and there are particular clusters during the day, but they don't fall the same every day. So what we see is, for whatever reason, lots of calls coming in quite quickly, but at different times across the day. So when you've got a fixed number of people to deal with them, it's quite difficult to flex to be able to pick that up. And the cause in terms of why we're seeing a higher dropout is because there are generally more calls. There are early thoughts only about how we can bolster that and pull other people in to provide extra backup to that line. So people that do less urgent work that could, if you like, be paused to contribute to periods of extra activity. But it is an issue that affects all services of this nature. It's you know, it's a national problem. We are, as I said before, favourable in terms of that rate, although it is dropping. But it's the nature of it, really.
Jemima.
Thank you. Yeah, I want to come back to Joe's point about it's something you think about when you kind of use this platform to talk about anecdotal stuff that's happened to you, because you do think, am I putting people off calling because they think, well, there's no point? But actually, and I did have that discussion with myself, but actually the data bears out what I'm talking about. And actually it may feed into the stuff we're talking about, call drops. Actually, if you're not answered after 30 seconds or something, you think, well, I know I'm not going to be answered for 40, 50 minutes. I don't have time for that, or I'm too ill to do that, or any of those things. So I do understand that kind of talking about it and shedding a light on it might be putting people off, but I think it's too important. And the fact that we're talking about it today, and I'm really grateful because of the motion I put forward in council a few weeks ago, that we're talking about it today, and that primary care will be something that you're talking about at your next scrutiny. We know we've got a problem in Plymouth. We just know it. And what I really, really don't want is for this to become normalised, for this to become an accepted thing. I know that the Plymouth Live covered the issue I talked about with my dad, and some of the commenters were like, oh, well, what are you complaining about? It took 10 hours for an ambulance to get to me. You know, so I don't want by some kind of attrition for us to accept this. So it's been encouraging to hear about your plans. And, you know, we've got a new health secretary. What would you want from him? What would you want to ask of him to support and develop the plans that you've already got in place, so that we don't normalise this, we don't accept this, and we can get back to what we have been and what we should be entitled to expect in terms of emergency response?
Crikey, that's an exam question, Jemima, isn't it? If I can be really honest, I think we need the focus to be on all parts of the pathway, not just on ED, not just on ambulances, you know, and so I think unless you focus on every part of the sausage factory, you just push the sausage up the chain. And that's the only way I can describe it to you, is you create a bulge in one place, and unless you do all of it, and I think, so for me, what I would ask is that there is clear scrutiny, focus, pace, investment where it's needed, an understanding of some of the capacity challenges around workforce and what else we can do around that. But it has to start from front to end, and that would be my clear request. I don't know whether Anna would like to add anything onto that, putting her on the spot, but you have to do home and away.
No, I mean, I think as we're describing this afternoon, there isn't a one place that will address the issues that we have in terms of current service delivery. So I think it is, you know, those conversations around where either investment, where workforce modernisation agendas, where perhaps, you know, some of the scrutiny, certainly in the landscape of the healthcare system, feels very focused in terms of the acute hospital. And actually, you know, I think through sessions like this, you can see, one, we're working together, but it's an opportunity to see that there are challenges across the whole, and that's very visible. So, and I think we need to continue to work in that spirit. And clearly, as Joe's alluded to, you know, some of the investment that is required around some of the infrastructure changes around UHP, the bed base, those types of things, as Councillor Finn has alluded to, and as Joe has described, you know, actually that's really positive, but that's some way off for some of that. So it's, you know, it's the here and now on that landscape as well is really important.
Thank you. Right. Joe, you'd more or less moved on to same-day emergency care and emergency department sort of by default more than anything else. Do you want to carry on with that now?
Yes, thank you. Should we go to the next slide? But I might just do an opening in terms of for those people that I've not met before. So we are one of the top 10 Challenge Trust for ambulance performances. And I think most recently, and I'll look over my shoulder at Dave, we're probably in the top 5 for the number of ambulance delays that we have holding. And the change between March last year and this year is, you know, incomprehensible in terms of the level of delays. And I will try and show you the point in time when everything changed for us, just in terms of some of our challenges. So you can see from the pictures on this screen that actually we've seen a reduction in ambulance arrivals, like I've explained, but at the same time an increase in people waiting. But at the top, an increase in the number of people that walk into the department. So I think that's pretty self-explanatory, Councillor Aspinall, but actually what I would say is that the huge challenge that we face is in being able to offload ambulances, and the challenge for that is space and flow and staff. So if you speak to any ED consultant, they'll say staff, space and flow. So I'll just try and use those three words as we go through the rest of the presentation. If we move to the next slide, this is the some of the same day emergency care. So you can see from these coloured bar charts that year on year we've seen an increase in our same day emergency care offer. And in particular this year, where at the early part of the year we met with all the consultants and asked them to resurrect the pathways that had been turned off through COVID. And the reason they were turned off through COVID was because of the risk of people turning up to an appointment with COVID, bringing it right into the hospital. So those started, and we've seen a continued improvement in how we're doing. And as I've said, we know we can do better, and we've looked at other models in other parts of the country. RDU do something better than us in terms of cardiology chairs. So we're looking at every opportunity to do better, and the team are working on that as we speak. So every week we see a slight improvement in that. Next slide, please. And then these are some of the areas of challenge. So we are in the National Hospital Discharge Programme for what we call simple discharges. So that's people like me or you. We would come into hospital, have whatever we need and go home, don't need anything. Then we have complex discharges, who are people need anything from a range of a package of care to a dementia care home. And some of the things that we're challenged with is discharging more people by lunchtime on the day. And actually, if we discharge more people by lunchtime, we could pull more people through ED and reduce the number of ambulances waiting and the number of people waiting over 12 hours. And the target's 33%. And as you can see, we're achieving about 25% discharges by midday. But what that doesn't capture is that we've built a bespoke discharge lounge, which has 17 to 20 chairs. And every day on top of this, we fill the discharge lounge. They don't count until they've been discharged, but they go into the discharge lounge. And on top of that, every day by midday, we've put 20 patients in a corridor on a ward to create space. So we are mitigating our performance on this, but we still need to fix this. So our medical director is leading a piece of work around making sure everyone's medicines are ready, and that we identify what the criteria are to allow someone to be discharged when they're ready. Easier said than done with complexity, but he's working with the emergency intensive support team from NHS England, and we've got a whole programme that reports to me and Anne as the Chief Exec every Thursday at 5 o'clock on how we're doing with that and what progress we're making. So we could do better on that. In terms of discharges by 5 p.m, the target is that we should discharge 75% of our daily discharges by 5 p.m, and we're cracking that most days, and we've stretched that target to 80%. The last couple of months have been difficult because of COVID. And just to cite you on our current COVID position, we peaked on the last wave at the end of March at about 135 patients. We're an organisation of 9,000 staff, and at any one time we have approximately 500 staff off with illness-related issues. At the peak of COVID, we had about 500 staff off with COVID. So we had about 1,000 people off work during that period, which peaked at the end of March. We saw continued improvement through April. And then just towards the last week in April and the first 2 weeks in May, we saw a really rapid improvement. And that was A, because COVID reduced, and B, because the government issued the Living with COVID rules, which we implemented. Kath, who's my new Deputy Chief Operating Officer, I've not introduced, but you'll meet at various points, did a piece of work around putting the wards back to where they were pre-COVID. And we took every opportunity to do as much surgery as we could and get everybody back in the right place to reduce length of stay and improve flow. And we had some good progress. But as we sit here today, we've got 120 odd patients in our beds with COVID again, and we've got 440 people off with COVID. So we are seeing another wave of COVID, albeit not as publicised as previous waves because we're trying to live with it, but it is impacting on what we can do every day. So I think we're just going to have to learn to live and adapt and dynamically respond to it. But we've had whole teams taken out this time. So, you know, we lost a load of ODPs who help surgeons in there, you know, 9 ODPs yesterday, 7 theatre lists, everyone trying to work out how to get everyone in for surgery. So we are sort of dynamically learning to deal with that. But from a discharge perspective, we are doing really well in terms of discharging by 5 p.m. What I'd hoped I would see as a result of implementing what we call the full capacity protocol, which is where you put a patient on every ward when you're full in ED, is that we would see a reduction in ambulance delays and a reduction in people waiting a long time in the emergency department. And to be honest, we haven't seen that. And I think we're just so crowded that actually when we take people from ED in the morning, we've already got the best part of 2 wards of patients in ED on top of ED waiting for admission. So it then takes the patients from ED and it takes some ambulances in, but it's not having the impact we need. And that's because of our general level of crowding. So we're operating at about 104% occupancy every morning when we come in. And you'll know the recommended occupancy levels to turnover are 85%. Well, we've never aspired to get there because we know that would be too hard. But I think if we could operate at 94%, 95%, we might win with a shot of getting our flow better. So that's one of our sort of wicked challenges at the moment. The things that affect occupancy are length of stay, like I've discussed. And the things that affect length of stay are the sickness of the patients that come in through the front door, the complexity of the patients that we're operating on, the impact of COVID, and actually most people in the hospital are in with something else and COVID on top, but we still have to take infection prevention rules around those patients. The number of people that are waiting for discharge that are complex, and obviously sometimes the level of crowding just makes us less efficient than we would be normally. We've got an aspiration to reduce our 12-hour delays in the department, and that's part of our improvement plan. But as we speak, we've got space for 75 people in the emergency department, and every day at this time of day, we'll have about 120. So we haven't even got staff for 75 patients because we're recruiting, we're not far off, but we're a department built for 75 that's running in excess of 100 patients. We've put an internal corridor back in, so we're on top of the 75, we've got 10 patients in the middle. You know, we've got more patients in ambulatory, and patients obviously then waiting in the car park. So we are hugely challenged at the moment in terms of being efficient. If I could go to the next slide. Oh, you're there on the next slide. So again, one of our real challenges is length of stay. So the work that Kath's done around getting the wards back in the right place has wiped half a day off length of stay in the first month that we did it, which is really positive. Actually, it gives us about 25 beds back, and then we've had another COVID wave. So we haven't moved the wards around again, but we're going to need to take that efficiency as soon as we can once we start to get the COVID numbers start to go down. We have been advised, although we're not confident that the next 2 days will break the back of COVID and we'll start to see a decline again. So we're all touching wood that is the direction of travel that we follow. And then the bottom slide here shows you our patients that have been waiting over 21 days in hospital. So I'll show you another slide in a minute, but pre-COVID, about 75% of this cohort of patients, and this includes people that are fit and people that are not fit, so it's the total, 70% were complex patients who need some sort of complex care on discharge, and 30% are tertiary, so they've had open heart surgery, brain surgery, a renal transplant, or some of the specialist stuff that we do, and therefore are in the long wait table. And as you can see, we've been working with Anna and the team on reviewing every single patient every day. We do that anyway, but we've put even more scrutiny. That number is starting to come down as the COVID impact on the community has improved, and we've been able to move some patients out. I would say we've seen a particular improvement in Plymouth and a deterioration in Cornwall, and I've met with Cornwall recently to talk about what we might do about that, the impact of that. If I can move to the next slide, and I'll just move on to discharge, Mary, and then finish if that's okay. I've talked to you about the simple hospital discharge and the work that we're doing and the improvements we need to make. If we could go to the next slide. I'm really sorry this is a busy slide, but I wanted you to see the numbers because it's really important. We have a fantastic track record of working together on complex discharge in Plymouth, and that's been built up through years' worth of reviewing every patient every day together. And when you have a minute, if you look at the numbers, you'll see that from January 19 to June 2021, we were under 4% of patients in beds being delayed in terms of discharge. Detox in old money, no criteria to reside in new money. And you can see that from July 2021, when this very last wave of COVID hit us, it completely knocked us over. And therefore, the numbers went from 7.7% in July to a peak of 14% in February, 10% and 12% at Christmas, 14% in February, and again back to 14% in May. And, you know, in terms of beds for us, that's a change from an average of 30, 25 to 35 beds to over 140 beds at peak. So 6 wards full of patients who do not need to be in hospital. If I show you the improvement that's been made in the last few months, you can see in May that the improvements start in Plymouth in terms of reduction from 2,110 bed days lost to 1,400. But that if you look at Cornwall have lost 1,058 bed days. Cornwall account for 20% of Derriford's bed base, and Plymouth account for about 60%, 65%. So actually the proportion of delays from Cornwall is significant. And so I've met with the Cornwall leadership team just to talk through how we can work better together around some of the challenges that they're facing in terms of complex discharge at the moment. So I think we're really keen to sort of progress that. We've reset, along with the wards, our integrated hospital discharge team. So actually we used to have discharge case managers who would be assigned to wards and specialties, who would go to all the multidisciplinary team meetings and know all the patients and the staff. Obviously during COVID, all the wards got moved around, all the staff got moved around, we lost some of our continuity, we put that all back together. We're testing a hospital to home model, and this is, you know, we have a number of patients waiting for Home First or a domiciliary home package, and along with Live Well, we have a sort of pathway where some of our challenges are the waits to move out of hospital and the people needing therapy. So we don't know whether it will truly work, but we thought it was worth a go. So we've recruited some therapy leads and some reablement assistants. And our plan is for those patients who would otherwise wait in hospital, take them out with the therapy support, give them 2 weeks of intensive therapy. And if we can avoid a dom care package or a longer term piece of care, then we will. It's 5 weeks in. We've taken out about 60 patients, 3 have been readmitted and 1's needed a package of care. We are being highly selective at the moment because it's not fully established with staff. So we're choosing the easier patients, and the plan is to move to the more difficult patients. But I don't think we can afford not to try something. We haven't properly linked ourselves up yet, so we're just getting it going. But it is an effort to try and contribute to the system. And I think partners have been challenging as well as welcoming and making sure we get that right. And if we don't get it right, then we try something else. Anna, we've opened the short-term care centre. Do you want to take over from me?
Okay, so I think as Jo sort of introduced, a lot of work and some green shoots of improvement in terms of that. I think really important to understand that there's a mixture of challenges in discharge. So clearly capacity, but also actually how we're utilising that capacity in the most effective way. And I think some of the improvement work that we're collectively looking is how do we ensure that we get the social care lens back into hospital discharge, and really make sure that we've got that really good understanding of the community provision that's out there that isn't necessarily the prescription of a bed, if we're really going to make sure that we get the right flow. So as Jo said, a lot of work around how we increase some of that reablement capacity out in communities. We know from feedback that we've had from members around this table and from the public that actually having that timely access to rehabilitation in people's homes is definitely the model that we want to adopt, and actually how we start knitting together some of the provision, whether it be through the independence at home service that Gary delivers, the home from hospital service that Jo's team have started to deliver, the crisis response team that Live Well, how we increase that capacity to get people home when that's the most appropriate setting is absolutely kind of a key priority for us. And I think we already know that there's some opportunities to improve. We know that we have used over the last 2 years to support the acute hospital bedded care a lot, and we've acknowledged that in this room. So we absolutely have worked with care homes to step people out of the acute hospital to give Joe and the team as much flow as we can create. But we know sometimes that actually care homes, discharges to care homes is not the person's preferred place of destiny in terms of leaving hospital. And I think what you've probably heard from all of us today, that there's a balance of risk across the system at the moment that is challenged and constrained. We really want to address, how we use bedded care in the most appropriate way. And clearly the model that we're trying through the Patricia Venton Centre and that short-term care approach, which is, really good partnership working between Age UK, Live Well, the council, NHS Devon to really deliver that rehabilitation model in a bespoke setting with the right therapy is clearly something that we want to try, test, and then think through what that then looks like for the future. So I think, there's work in relation to capacity, there's work absolutely in relation to practice and making sure that we have the right professionals engaged in the discharge process is something that we're going to build back in through discharge arrangements, because clearly that changed very much as part of COVID response. And as Joe said, putting back together the integrated hospital discharge team, but making sure that we've got that real focus in terms of social care embedded within that is really important. So I don't think, in terms of absolutely happy to take questions, the slides speak for themselves. I think really important when we talk about patients with no right to reside, delayed transfers of care, as Joe's described, understanding the landscape of Derriford Hospital and the Cornwall, Devon and Plymouth dynamic when we talk about delayed beds is really important, as Joe's talked about. You can see that there's some green shoots of improvement. We're not back to where we would want to be, but I think we also need to acknowledge there's a huge amount of work that the teams have been putting in on a day-by-day basis to address what's been a particularly tricky issue that many members sat around the table have certainly had conversations, whether it be Councillor Tuffin when he was portfolio holder or Councillor Nicholson. This has been a tricky challenge for us as a system, but some good work, but still very much more to do, and will clearly form part of the ongoing ambulance improvement work, because what we have heard today is that actually we need to be looking at flow at the back door of the hospital, as well as how we manage arrivals and those types of things. So I don't think it's helpful at this stage, Chair, to go through all of the individual actions, but I think absolutely happy, joined by Ian and Sarah, to pick up any questions in relation to discharge performance.
Thank you, Anna. Lee.
Yeah, just a couple of quick points. What are you doing to address the Lloyd's pharmacy problem, which seems to hold a lot of people on wards waiting for medication before discharge? And I think you're doing a remarkable job, like you said, with regard to supporting individuals. However, an observation over the years when things actually worked with regard to discharge was the interventions of district nursing. Each GP surgery had a district nurse. I know, for example, should I've gone in, I've had 4 spinal operations. When I was discharged home, I didn't have to worry. The GP intervened. The district nurse was there. She took care of the dressings and liaised with the GP and the hospital. So I think there's a clear failing here again with regard to clinical commissioning groups and GPs, and it may be something this committee needs to address as we go forward. It's not just the hospital's fault that we have problems in the chain. We have to go back to the beginning, and I believe that especially district nursing is important to the needs of the consumer and stakeholder.
Joe, do you want to take the district nursing side?
I'll do the pharmacy one, and I'll hand over to Sarah. So it isn't Lloyd's Pharmacy in terms of the ward delays. Just for clarity, we have our own pharmacy. Some of the challenges are around making sure the prescriptions are written in time, with a workforce that's stretched, managing all of the patients, all of the outliers, all of the patients in the corridors. And so we've put in an electronic prescribing system, but there is more efficiency that we can make in prepping for discharge. So we might use Lloyd's for outpatients, for inpatients, and it's an internal improvement that we need to make.
Thanks. I guess just picking up on district nursing, so practices and primary care networks have attached district nursing teams. We've talked about workforce as a theme today. District nursing is one of those services that has workforce challenges. People at home we've heard today and we understand are more complex. You know, they're definitely sicker, but we definitely have attached district nurses to our primary care networks. We have link workers, so primary care networks know who their teams are and how to access them. And we're also bringing together not just district nursing, but our core teams in localities. So district nursing, community therapy, adult social care and long-term condition matrons working together to wrap around those most complex people. And I don't know if you've heard of something called Aging Well MDTs. So that's something where we get together with our practices and we have an opportunity to all virtually discuss people who are those most complex, who need that care in the community together and agree a plan. So that's working pretty well.
Interject on that one. The reason I say that was when my partner was seriously ill with the chemotherapy, we tried getting district nursing and support. What you're saying there is there's a system there, but clearly the system doesn't work because we tried everything in name only. So what I think the thing is that the pathway to that care needs to be refined, possibly come back to a GP surgery for a GP surgery to be able to order that care so that people aren't left alone knowing what to do and what not to do.
Yeah.
Sarah, sorry, can you describe how somebody gets a district nurse into their care? And I appreciate that some of the chemo nurses are different to district nurse teams,
right.
aren't they? So can you explain that differentiation?
Absolutely. Yeah. And I'm sorry to hear of your personal experience. So district nursing provides nursing care to people in the community who are housebound. So to access a district nurse at home, people need to be housebound or meet other particular criteria. So when people are maybe at end of life and they are going to need district nurse treatment in their own home, we would see people before they get housebound. For people who aren't housebound, there are other offers across the city. So we have district nurse treatment clinics for district nurse treatments like catheter care, wound care, that some practices do provide and other practices don't provide. We use Devon Doctors on Call for our call handling for district nursing. So anything out of hours, so over a 24-hour period, we have a district nursing service. It's run in localities by day, and then overnight, it's run on a citywide basis, just to be able to, manage it. So GPs, any community clinician can refer to a district nurse, and we've got a district nurse referral hub. So the GP practices would refer in through the district nurse referral hub. So it's an electronic referral that they can do. So the information that's already held on a system about a person is transferred across to the district nurse referral hub. There are clinicians in that hub who triage that referral, understand that they've got the information they need about that person, and then they would send that to the correct locality team to enable the visit to happen. As Councillor Aspel has talked about, there are other sorts of nursing care that aren't provided by district nursing. So chemotherapy isn't provided by district nursing. I think that's a separate service run out of University Hospitals Plymouth. So there are some things that are district nursing and some things that are not district nursing. And for our public, obviously, we want to make sure that people understand, and have clear access criteria and understand who's providing their care.
Thank you. And presumably the GP should be able to explain to somebody which is doing which. Or you can ask John, who may well have good knowledge from his experience. Yeah. I think the NHS has changed so much over the last 20 to 30 years. I mean, Joe has seen
I was a district nurse in those days. Let me just tell you that I was a district nurse.
It's changed a lot.
Changed.
Okay, Jemima, you're next.
Thank you. Yeah, that discharge information is really interesting. So the sausage that you talked about, Joe, it's not an entirely Plymouth sausage. Actually, there's a Cornish bit and there's a Devon bit. So there's pressure that needs to be brought to bear on those partners, because that, you know, because obviously I care about everybody, but actually I care about Plymouth, and that will be an impact on those numbers. And I guess I don't really know who wants to answer this, whether it's you, Joe, or I know Dave, you're away from the microphone now, or James perhaps. Given all the improvements that you've outlined and described today and the plans and all the rest of it, when do you think that Plymouthians can expect to see fewer or no ambulances in the car park at Derriford, or that their calls will be dealt with in a more timely way, and when I can stop tweeting Sajid Javid or Steve Barclay now? You know, realistically, when do you think those improvements will start to be returning us to a level of a system and care that we used to be able to expect?
Crikey. I can't give you a time or a month. I can give you what would need to be true for us to expect for that to happen. Does that make sense? So feel free to prod me back at the end of it. But we know we don't have enough beds for the capacity that we need. We've been really fortunate this year to bid for money through NHS England for orthopaedics, which is one of our areas of long waits. I'm sorry to go off on a tangent, but it'll make sense in the end. So we've bid for 3 theatres and extra orthopaedic ward. And providing we can get all the builders and the equipment in time, plans are to get them ready for March, April next year. Within that, there's room. We've got a new eye infirmary, which has moved some of the theatres outside currently into the disabled car park, but will be a new build, which will give us extra capacity for eye surgery, but has already released 2 theatres for complex stuff and a ward footprint, and the plan is to put another medical ward in there. So there are some infrastructure things in terms of our bed base that will start to eat away at some of the structural deficits that we've known about for a very long time and since before COVID. We're building the new urgent emergency care centre. That's 2 or 3 years away. So I think by the March, April next year, we will definitely have more elective capacity, which will mean that we are not trying to squeeze everything, particularly the emergencies, into the same box. And also we're not taking some of the elective capacity away. We do need to go back to a world where 35 beds are full with delays and not 135 or 105. That would also need to be true. We would need to have some of the workforce challenges addressed across the entire system that would enable us to be able to service the extra capacity, the extra demand that we see from pre-front door to back door. And those are all things that are in our plan. So I think we've given ourselves some trajectories to try and get some of those things in place. So we've said we want to make we did say we wanted a 20% reduction in ambulance handovers by September. The new target is 0 ambulance handover. But you know, we've set ourselves trajectories. We've set ourselves at a trajectory for complex delays. We're internationally recruiting to clinical staff, both nurses, radiographers, pharmacists and doctors, and I know Anna's got a whole recruitment campaign in place. And I think that it's quite hard to say by September we'll have fixed this, because that won't be true. What we will have done by September, we've worked extremely hard on all the things we can sort. I think we could do, you know, there are always nuclear options, but when you do a nuclear option, you stop a service to a person of Plymouth that's needing something else, and it's a risk-based system. Yeah, I think there's more questions, and Anna might have some more answers.
Thank you. Yeah. Natalie, you wanted to bring something?
I just wanted to follow up on that. Thank you, Chair. You said you're recruiting internationally. Obviously, we have a lot of Ukrainians that have arrived in the area. I'll declare an interest in my work. I've been working with some of the Ukrainians who are highly qualified. The people that are coming over are really qualified. We've got speech therapists, we've got child development psychologists, we've got all sorts, doctors, medical, you know, that are there. What are we doing to try and fast track for them to be able to actually look for a job that is suited to their skills and experience, rather than them, unfortunately, maybe having to look at something that actually is less than their skills and experience. They've got years of experience, and are we tapping in somehow into that?
So I'll ask Anna, but is there, as part of the programme for supporting the refugees and the people that are coming in, is that part of your programme for Plymouth City Council? We're massively up for supporting Ukrainian refugees, and many of our staff are hosting families. So I was just talking to someone about it yesterday. So if we've got people with skill sets that we can use, why wouldn't we fast track them through whatever process it would take to make sure we can get them appropriately accredited or professionally registered? We would absolutely support that.
Back on that, obviously the Job Centre, we're referring them to an organisation I work for. So the Job Centre have information about the skills that somebody's had. So whether or not some partnership
Need to find a place in the middle,
to actually connect together.
And I think part of the process is, how do we get people into the workplace? And unfortunately, there's so many hurdles to jump, because I've sat on things for NHS England looking at doctors from Europe coming over, and they've got to be able to prove X, Y, and Z and whatever. And unfortunately, refugees may find it more difficult to get that information. So let's hope we can find ways forward. But again, this will be something that will be the Department of Health and Works and Pensions, etc., having to work together, won't it, to make this happen? And I think that's incumbent on all of us to be pushing for that, certainly. Anna, you wanted to come in.
So I just wanted, it was an agenda at the Skills Partnership. So one of the things, clearly we've talked in this committee, variety of committee, about workforce challenges collectively, absolute commitment across all partners that rather than one organisation going on a recruitment drive that then destabilises another part of the system, we cannot do that in the world of health and care. So we've established a skills partnership supported by DWP, training colleges, university, and all of our partners. And that particular issue in terms of how do we support those Ukrainian individuals who are arriving in the city with all of the skills into some of the opportunities that we have was specifically picked up. So I might just pick up with you, Councillor, outside of here, just to ensure that the right people are connecting that, because certainly DWP were in the room and had picked up that there was an opportunity there. I think we just need to make sure that it's knitted together, but absolutely on the agenda in terms of welcoming those individuals to our city and ensuring that we are creating opportunities for them to utilise the skills that they absolutely have. So thank you for raising it.
Thank you. Right, folks. Well, I think we've given this a pretty good going over this afternoon. I certainly don't think it's the be-all and end-all of it, and I can see that we're going to be inviting you back for certain bits and pieces. I'm not going to put any time frames in at the moment. The pressures on UHP are really tough on all the services. I just want to put a little spoke in the wheel and say here, my daughter lives in New Zealand, and as we know, they closed down for 2 whole years, then they're now open, and their COVID rates are rising, but they're also seeing a really, really, really bad flu season that they've not had for 2 years. So sorry, Joe, we've got flu on the horizon as well.
Yeah, we do know that. My best friend lives in Australia and she's just been to visit. We are planning early for flu this year. We always knew we were going to have a flu season after, well, I say after COVID, we've got COVID again. And I think that's why we do need an injection of you know, a flu and COVID. We do need an injection of, we absolutely, I just want to give you my absolute commitment that we will do our utmost to do everything to the best of our ability for the patients of Plymouth, Devon and Cornwall. And I think we're all collective on that. Yeah. But the challenges are significant. And every time we go through a COVID wave, it creates a different set of challenges. So in wave 1, it was stop all operating and prepare for Armageddon, you know, and in wave 2, it was, you know, create, you know, dedicated spaces. We didn't really see that many people. We've seen the latter end. And, you know, when we think about deprivation in Plymouth, we have something like 10 to 15% of our population that are less vaccinated than elsewhere. And we've seen higher rates, as you know. So I think every wave comes with it new learning. You're more than welcome at any point to come and have a walk around with any of us. Me and Kath, we are experts at showing people the lay of the land. And, you know, if people do want to come and visit or contact us for any information in the meantime, you know, very happy to do that.
Yeah, thank you very much indeed. And I really want to thank all of you for coming this afternoon and giving us your time. It's been essential that we get the picture and the full story rather than getting little bits all the time. And that's why it was essential to understand urgent care and emergency care. For those of you that got away with not being asked any questions, Gary and Craig, we will pick on you some other time, all right? So thank you, folks. If you want to go out quietly while we just finish the meeting, you are very welcome to, all right? And Tony, thank you very much indeed for coming along, much appreciated. Okay, folks, next item is tracking decisions. Right, Ross, what we got on tracking decisions? I think most of it's been done. Well, I say most of it's been done. That first one hasn't.
I don't think there was a formal response made by the City Council Chair, but there was individual responses submitted to the cancer plan. Other than that, I think they're all covered.
Yeah, there's nodding frantically from Craig, so that's good. And in front of you, you've got our work programme, and I apologise for the fact that there's no dates besides when we're going to be doing it, but be very, very sure that we will be doing primary care in September. All right, I think it's the 7th of September, and that will include pharmacy and dentistry. I think from what we're hearing, we need to be pushing again on dentistry. And Jemima, obviously, we will be making sure that we invite Children's Scrutiny Chair and Vice to come along and join us for that. Patrick, you wanted to say something?
Thank you, Chair. I was a bit alarmed in the meeting about the Colin Campbell Court Health and Wellbeing Hub, given the fact that there's an item which I'm not sure if it's generally about health and wellbeing hubs or about the Thrive Fair Share schemes and delivery impact from health and wellbeing hubs. But anyway, I think we ought to be bringing to the next meeting, and it may have to be in part 2, but an item on the update on the delivery of the health and wellbeing hub at Colin Campbell Court, because ever since planning permission's been granted in about March, I haven't heard anything since. So I think it's about time Scrutiny were on the case.
We can add that in, not a problem. Okay, yeah. David?
Not a question, more of a plea. I'm sitting here, and today we've seen a vast selection of healthcare professionals, etc. My association with people like that is as a patient. Can we please ask them not to use capitals? I mean, I've gone through most of it. There's a couple I don't know what they are, but they work with them every day, and therefore, you know, they know. If you want to know something about colour segments, I was a painter and decorator. I can talk about that all day and baffle you all on that. So could you please just ask them when they come along in September, please don't use capitals unless it's absolutely necessary.
We will be making sure that we get those 3-letter abbreviations sorted.
If they could do a list or something.
And yes, and I think that's something that Craig, Anna and I will need to chivvy them along, etc. And we'll rope in Ross as well as much as we can.
I think we've got one chair.
Yeah, we'll just need to tidy up the one we've got, I think, basically. All right, so we will do that with pleasure. Far be it from me to, I mean, and of course the problem is one group's 3-letter abbreviation is somebody's different, so you know it does get, but we will try our very best. Okay, folks, right, well, bearing in mind that my list said we'd finished at 4, we're doing pretty well. So Thank you, Ross, thank you, Craig, and thank you, team, for, see, you're all surprised it's so late, you've enjoyed it so much. Thank you very much indeed for your input today. It's been a good session, so have a pleasant evening and hope you can get cool somewhere.